Check. Good morning, everyone. Distinguished dignitaries, esteemed speakers, innovators, partners from the healthcare and insurance ecosystem, and dear participants, a very warm welcome to all of you. On behalf of the National Health Authority, it is my pleasure to welcome you to the NHCX Innovation Meet and the finale of the NHCX Hackathon being held here today at IIT Hyderabad. To begin the inaugural session, may I request our distinguished dignitaries to kindly join us on the dais. I respectfully invite Professor G.N. Shastri, Dean, IIT Hyderabad, Dr. Girdhir Gyani, Director General, Association of Healthcare Providers, India, Shri Saurabh Ghor, Secretary, Health, Medical and Family Welfare Department, Government of Andhra Pradesh. Shri Kiran Gopal Vaska, JS and MD, ABDM, NHA. And Dr. Sunil Kumar Banwal, Chief Executive Officer, National Health Authority. Thank you, and we are truly honored by your presence. To formally welcome the gathering and set the context for today's event, I invite Professor G.N. Shastri, Dean, IIT Hyderabad, to deliver the welcome address.
Very good morning. After a wonderful first day session, we are entering into the second day, and we are honored and pleased to have Dr. Sunil Kumar Banwalji, CEO of NHA, to come here and then interact with all of us. And we are also very happy that Dr. Giridhar Gyani and Dr. Saurabh Gaur and others, our JS NHA, are also there for the last. Yesterday it was a very eventful discussions on the stage and off the stage, and I am sure that it's a very, very important area where many people, when they get into a situation like this, everybody will come that how much of a confusion or lack of transparency is there in the system, which will make you wait when the patient is cleared by the doctors and before they can be taken to home. And the hackathon has also provided the solutions. And I was talking to our Dr. Sunil Banwalji that some very important areas, all areas are important, but something very important for any country is health, education and agriculture. And we have to use the best of the artificial intelligence and other solutions in these areas, and definitely this innovation session will help us to bring the best of the best solutions from AI and Gen AI and agentic solutions to come, where we will be able to have we will be able to address the gaps, and the efficiency of the system will improve and the transparency will improve. And as I have talked about the IIT Hyderabad, I just will take only a very few 2-3 minutes to just tell you that IIT Hyderabad is a 600 acres of sprawling campus with 5,800 students with 340 faculty members, and we have a lot of focus on the innovation, translation and startups, and we are very happy that in many areas we would like to emerge as a cluster of excellence, because earlier many institutions would like to go as a center for excellence, but as IIT Hyderabad is a growing city, we were very much looking forward to work with everybody within Hyderabad, because there are so many institutes where we can come together and also coordinate with many other institutes in the country. Like that, there are several areas which we have identified, like for example, in critical minerals and semiconductors and additive manufacturing and mechanical and aerospace, and we are very strongly interacting with the armed forces, Air Force, Navy, and our DRDO has a center for DRDO DIA. And a very, very important area is AI in health. I would like to tell you that in 2019, IIT Hyderabad is the first institute to start BTech in artificial intelligence. At that time, only 2 institutes in the world have undergraduate program. One is Carnegie Mellon and the other is MIT. And IIT Hyderabad is the first one to start. Although we are the first ones, there are many other people who have adopted and they are doing extremely well. And we have a separate department for artificial intelligence and separate department for computer science. But there are a large number of scientists who are working across the different areas. For example, I come from biotechnology. We have a biotechnology and biomedical engineering, and 20 departments are there. And we all will be very happy to work with people who are working in the healthcare or insurance or claims or medical diagnostics, or how we can actually involved in the drug discovery to genomics to geriatric care, and trying to assist people in the palliative care, prophylactics. There are quite a few challenges that are there. And when we talk about many of the medical problems, it is actually the mechanical engineers and electrical engineers which might play a much better role than medical doctors in some ways. But IIT Hyderabad is very actively working with LV Prasad Institute and Basavatarakam and AIIMS and MJM Cancer Hospital. We have a very interesting program called MTech in medical physics, where for example, if somebody works in a cancer hospital, they learn the oncology and biology related things from them, and where they learn from lasers and optics here. So they will do a 1-year project where they will be specialists in applying the science and technology to medical problems. And similarly, we also have several MTech students who are doing project in hospitals, and they try to work in the hospital, and then after 1 year they will have to just submit a product. As an exception, they don't have to submit any thesis. At the end of the day, they will have to give a product, and that product will be their MTech thesis. So like that, there are several things that we can do, and we are open for doing anything that we can use the innovative strength of IIT Hyderabad for useful. I just wanted to conclude that India is an extremely great country in converting wealth into knowledge. Probably no other country will come anywhere near to us when you just give some money and then produce papers or patents. But unfortunately, we are very much behind in converting our knowledge into wealth and knowledge into well-being, knowledge that we generated for the public good. So this is the way, and today's in the innovation meet, we are extremely keen to see that how the knowledge that we generate and the whole globally it is generated will be useful for the global good and especially for the India good. And I just wanted to conclude by saying that yesterday I said already, Technology Research Park and Technology Innovation Park that we have. Anybody who has an idea for innovation, we will incubate it in IIT Hyderabad. And Technology Research Park, we have more than 330 startups, and we are very happy that these people in the last 5 years have risen 1500 crores of turnover by taking only some 10 crores of input. So there is a lot of potential, and I am sure that the institutes like IITs and central universities and NITs and all the universities should work with agencies like this and see that how we can develop technologies that are relevant for the country. Thank you very much.
Thank you, Professor Shastri, for those kind words of welcome, your commitment to innovation, and for hosting us here at IIT Hyderabad. Our next speaker has long been a leading voice representing the interests of hospitals and healthcare providers across the country. It is my privilege to invite Dr. Gyani from AHPI to share his remarks.
Dr. Banwal, my friends on the dais. At the outset, let me compliment National Health Authority, IRDAI, and of course the IIT, Hyderabad, for hosting this very important meet. In fact, this exchange you may consider a small part, but I see it in a larger context. Because if you see 2017 policy of healthcare, the universal health coverage was predominantly highlighted by the government at that point of time. Now, universal health coverage actually means making healthcare available, accessible, affordable, and of course, acceptable in terms of quality. And I think now, of late, if you see now, I can see, here we are attending meet. Monday we have post-budget conference. Then Niti Aayog is holding meetings. Series of meetings are being held to give push to to realize the universal health coverage. Now, you see, the first and foremost is that we make infrastructure available. Let us say, in 2022, when we did the study, there was around 2.1 million beds. I'm sure now 15% addition must have happened. What we need is 4 million beds to make it happen, 3 beds per 1,000 population. Other area which we have drawn attention of the government is accessibility. So because we are in Hyderabad, so let me quote the example of Telangana. Because in Telangana, as per our directory, we have 126 hospitals with 100 bed and above, out of which 118 are in Hyderabad and Secunderabad. So I think that is a kind of, problem which we are facing in terms of accessibility. Then whole Telangana has to come to Hyderabad for tertiary and quaternary care of. So these are some of the issues, which we have to work. But making 4 million beds obviously will going to take a lot of time. So till that time, I think the technology is the only way we can bridge this gap. And I think this exchange we have been talking for now a few years. And I think this is the high time that I have suggested to our CEO that now is the time to give a real push. And I think the AHPI, with more than 20,000 hospitals as the members, are committed to make this mission succeed. But push has to come from NHA. We will work solidly on this very issue. Now, it also just reminds me one of the issue, because I am again here in Hyderabad. So in 2007, I think Andhra Pradesh combined was the first state in the country to launch Arogyashri. I think we, of course, talk of the Ayushman Bharat, which is, of course, the mega scheme. But I think the initiation came from 2007. And I remember the name of the officer, Babu Khan. Okay, sorry. Because I came and met him, the kind of technology which he used at that point of time to track the patient through the hospital was remarkable. I think that scheme was so successful, but I think I must point out to you here that around 40% of population was supposed to be covered under that scheme, for the below poverty line population. But today I am told Andhra is covering more than 90% of the population. It is one way it is good, and one way I will say, because anyway, I will not mention on that. But what I am trying to say is that technology was used at that point of time. And I think this exchange will become a breakthrough kind of, and I think there are few irritants which we are all aware about it. Because we are aware about it, we will be able to solve it also. So I think I once again commit on behalf of 21,000 plus hospitals that we will make this. I am seeing that in next 1 or 2 years. Let me tell you, when we launched NABH, because I am known more for the NABH. So, in the first year, when we launched with a fun and fair, we thought hundreds of applications will come. Hardly 36 applications came. Next year, when we awarded 5 hospitals out of this 36 who qualified, and Dr. Abdul Kalam, you happened to come as a chief guest, I think the message went around, oh, President of India gave NABH accreditation. And then next year, CGHS gave the incentive that we will give you 15% more money if you are having NABH. That made 300 plus application next year. So what I am trying to tell our CEO here, that all such initiatives, first you need awareness. Through awareness, some people will come. Then you need some incentive, more people will come. And then, of course, you need bit of regulatory push. I think these are the whole known methods which we will have to work to make it success, because this has benefit for one and all, for patient, for insurers, for hospital, and above all, the government of India. So I think with that, I finish my, again, I compliment the NHA, IIT, and the IRDAI to launch this mega scheme, and we are all committed to make it success. Thank you very much.
Thank you, Dr. Gyani. We now move on to our next distinguished speaker. May I please invite Shri Saurabh Gaur to share his remarks.
CEO NHA, Banwal sir, the host, Dean of IIT Hyderabad, I'll just put it, don't worry, I'll put it at a proper time. Yeah. Other distinguished guests, my dear colleague Kiran, other distinguished guests on the dais, and dear friends. It is my proud privilege to be a part of this session here today. I am Secretary, Health, Government of Andhra Pradesh. But with my prior work in Government of India as Joint Secretary METI, I identify myself as a technocrat. May not be such a great thing talking about this here in IIT Hyderabad, but still we now among the bureaucrats also try to generate some kind of domain expertise so that we are in tune with the demands that we are faced with in public administration. What I intend to do today, sir, with your permission, is present how we are partnering in Andhra Pradesh in enabling the Ayushman Bharat Digital Mission, and the fact that technology is going to be playing a most important role, in fact, today, in terms of bringing equity as well as access in healthcare, and how ABDM and its constituents, the entire digital public infrastructure is enabling that, and how do we perceive it in the state of Andhra Pradesh. I have a small presentation also which I'll take you through, and then I have 2 live cases also, time permitting, I'll take you through that also. Just a minute. Okay. Nothing to come up. Yeah. There it is. So, Andhra Pradesh is among the leading states in ABDM adoption in terms of we have, as part of the Aadhaar-based derivatives, and with ABA being the derivative in the health space, similarly APAR being the derivative, the students here are a part of higher education setup, and all of you must be using APAR IDs, or whether similarly in agriculture also it is the Krishak ID, which is becoming the derivative of Aadhaar in agriculture space. So in Andhra Pradesh, we believe a lot in the power of having these foundational blocks of the digital public infrastructure, and the state has gone an all-out approach of making ABA numbers for the entire population. So, and the point that you made, sir, in terms of whether we should be having insurance for everyone, a state-sponsored insurance for everyone, I'll probably respond to that also. So we have 4.91 crore ABA IDs. In terms of percentage, it must be among the highest in the country. I'll not say first. This is some overreach, over-enthusiasm by my team. But we are taking it very seriously. Similarly, the other foundational blocks, the HFR ID and the HPR ID, the health facility registration ID and the health professional registration ID. For these two also, we have been working tirelessly and ensuring with the nursing council, with the IP medical council, with the paramedic council, every health professional in the state should have the health professional, should be in the health professional registry and have the HPR ID, and every health facility also. So whether they are a part of the NHA or the Ayushman or the NTR Vaidya Seva, the Arogya Shri, with the, what do I say, with change of government, you get these kind of flavors in the name. But today the scheme is called NTR Vaidya Seva. So NTR Vaidya Seva, we have around 2,560 hospitals, and ensuring that each of these hospitals have the HFR ID. And there are 11,000 odd hospitals and clinics under the Clinical Establishment Act, or each of them having the ID. Recently we had passed a law in the State Assembly in the current session only. We have brought Ayush facilities also under the Clinical Establishment Act, and each of them will also be getting the HFR ID, and each of the Ayush practitioners also getting a health professional ID. And then generating health records. So every instance of citizen interaction with a health facility and even a health extension service. If there is a pregnant woman who is getting an antenatal care checkup, so in the RCH portal, the Reproductive and Child Health Care portal, apart from the RCH ID, the ABA ID should be there, and then the system becomes a ABDM M3 compliant system, so that the records get pulled onto the patient health record. Similarly, whether it is the NCD, the non-communicable diseases screening that is happening, if you are going to a primary health center or a village health clinic, or so there also our systems are ABDM compliant. And then the secondary and tertiary sector, you go to a 50-bedded, a 100-bedded hospital, or a district hospital which is a 1,000-bedded hospital also. Each of these becoming compliant to ABDM architecture, so that every patient interaction can be fetched onto a patient health record, and bringing the UPI moment for health, the UHI moment in terms of a unified health interface getting developed is what state is tirelessly working for. So today, any citizen interaction that happens in a primary, secondary, tertiary healthcare is ABA enabled, so that health records are getting generated almost universally in the public health sector, and the endeavor with the recent NHA guidelines that have come for in the private sector also. I think 2 days back only you released that, sir. So we actually spent 4,000 crore rupees on the Arogya Shri. It started with the 400 crore rupees at that time in 2007-8, and Babu actually did a fantastic job. In fact, and today we have the new version of the software also, but because government is giving 4,000 crores and almost 70% of it goes to the private sector, so we have that leverage available with the private sector also to make them fall in line with the ABDM standards. So adi kuda cheyadaniki veelu padta undi ani, and ensuring that they are also becoming ABDM compliant is what we are aiming at. So all the health facilities becoming compliant, and generating tokens, a scan and share approach, so that people also get used to, they have a patient health record app in their mobile, and they use scan and share while booking appointments, and they are able to fetch all the records also. So with these foundational building blocks, the architecture that is taking shape and the digital backbone that is developing, we are calling it Sanjeevani. This is what you will probably hear our Honorable Chief Minister, Mr. Chandrababu Naidu, probably talk in almost every meeting that he holds about health, and every discourse in public that we talk about. We had the opportunity to present it to the Gates Foundation and also in the India AI Summit recently. This is our digital health and care coordination model, and the digital nervous system also that we are bringing. So essentially, the point that we are looking at a citizen-centric continuum of care across institutions, a digital nerve center, and I will give you a glimpse of that center also, where there are, so all the data, whether it is from the extension services, from the reproductive child health care services, or the NCD screening, or the communicable diseases, or the healthcare facilities, all of them coming to the digital nerve center, and a lot of predictive analytics getting built on that. And the point that you are making, sir, in IIT Hyderabad, we are looking at engaging very seriously with this digital playground that is available with us, with all kind of innovators. And I'll talk about the MedTech Innovation Challenge also that we have done. And we have a very strong climate health program also, it's called AWARE, where not at the individual level, but at the Gram Sachivalaya level, we have data pertaining to diseases, the vector-borne diseases, whether it is dengue or malaria. Similarly, the non-communicable diseases also, the cancer grid, the diabetes and the hypertension data. Recently, we had a scrub typhus incident, so scrub typhus is another layer we have added. And building predictive analytics, working with Art Park, for example, ISC, Bangalore, and running the predictive analytics for dengue is what we have started with them. But then adding on to more layers also with that is what we are looking at. And we have done a pilot in one constituency, Kuppam, which happens to be the constituency of the Honorable Chief Minister, where we have established it now. So today, all that I talk about, I'll show you on the platform also, how is it actually working out. And in the primary health care, primary health center, the 12 CPSC services, all of them are getting reflected on the Sanjeevani platform. And today we are looking at expanding it to Chittoor to phase 2. So again, and then comprehensive NCD assessment also that is happening. I'll probably take you through the portal itself. Then there is pharmacy module, lab module, and then AI ambient listening also. We are trying it with Eka Care and Valedictory, two startups or two Eka Care is no longer a startup. They've raised quite a bit of funding, but both of them getting integrated with our next gen for primary and secondary, for tertiary, secondary and tertiary healthcare, and for primary healthcare, it is Valedictory, another startup with which AI ambient listening module is working. Ultimately, what we are looking at is getting a care planogram and at population level, getting a wellness meter for each and every individual. So while ABA, so compare it with, for example, what UPI enabled was, or what the NPCI, the National Payment Corporation System of India enabled was having ownership or not ownership, but essentially playing around and developing the standards in the payment space so that the digital backbone was established, or the DPI, the digital public infrastructure was established, and that's what is happening with the NHA today, with the DPI getting established and ABA as the government app, but then all other PHR apps also, whether it is Briefcase or Eka Care. In Andhra Pradesh, we'll come out with our own app also, working with a partner. Presently, we're working with Tata MD for this, and at population scale for all the 4 crore, 5 crore people having the digital care planogram getting established and a health meter, and then making it at community level, a community health score and a mandal health score and a district health score and so on and so forth, the constituency health score. The Chief Minister gets very passionate about actually making it a citizen movement and a community movement, and holding even the MLAs accountable कि भाई आपके constituency के अंदर ये चल रहा है. This is how NCD scanning is happening. This is how today actually every maternal death, today we have had 227 maternal deaths in state of Andhra Pradesh in this year. Every maternal death gets flagged up to the Chief Minister level. So you'll have to believe it in the kind of level of detail. So whether it is a facility audit and the community audit that happens for every maternal death, it goes up to the Chief Minister level and where he gets engaged with this. So every woman getting counted for so there are 7 lakh pregnant women, which is the ASHA worker, who is the ANM, which is the 104 ambulance, the Talibidda Express ambulance, which is attached to that, which is the medical officer who is attached, whether she is a high-risk woman, what is the anemia standard, all of it is available on the dashboard. Okay, I will probably take you through, these are the slides, but what I'll do is, actually I'll take you through the actual, what do I say, dashboard itself. Okay, so this is the Sanjeevani Digital Nurse Center dashboard. As of now, it is running in 2 districts, 2 constituencies, essentially. We have registered population, all of it is, what do I say? So 87% of the, 85.7% of the population in a way has been registered on the platform. You see the gender parity is also almost similar. And how many of them has actually had any interactions through whether going to the hospital for a service or we doing a extension outreach service, all of that is also available there. And the CPSC services, the care in pregnancy and childbirth, the neonatal and infant health, the adolescent health, elderly and palliative care, population management, NCD screening, communicable diseases, ophthalmic management. So all of these, the 12 CPSC services that are defined by Government of India, all of them are getting covered. As of now, emergency, burns and trauma, that comes through another system. It's not getting populated in this dashboard. And the other beautiful part is, look, the services, the out of the total calls that are coming, 66,000 calls that have come to the call center. A typical government call center, there will be lots of incoming calls, and the response is what it is usually. वो पूछेंगे भाई डॉक्टर है कि नहीं है, ये है कि नहीं है. But here the beauty of the system is that out of 66,000 calls, 8,000 calls are patient initiated, remaining 58,000 are initiated by the brain center, where they are making calls and telling you that you have missed out an NCD screening event, or you should have gone to a particular facility, or there is an antenatal checkup that is due for you, or an immunization event that is due for you. And so we are able to actually send these nudges very strongly to the population and tell them that this is what needs to be done. I'll not take, and then there's the pharmacy module, and the citizen app also now, the downloads have started happening, and the citizen health screening platform, where we are doing 41 tests, working with AIG hospital also in Hyderabad, and doing a risk profiling of the people based on that. So there is the lipid profile, the kidney function test, and so on and so forth. And based on that, getting a profiling done on the anemia, the blood profile, the cardiac profile, the kidney profile, diabetic profile, and the liver profile. And based on that, identifying which are the critical cases, and then referring them on to the institutions. And what we have found is, actually through this, citizens who had no prior diagnosis also, today we are able to reach out to them and tell them that you should be visiting a particular hospital. So I believe all these are becoming this is the platform, apart from the building blocks, the ABA ID, the HPRI and the HFR, the platform is also emerging, and the care planogram is also coming into picture. So with all of this, I think we are positioned well to be able to take it to the next level, and have a health app being done at the population level, a consent-based data sharing, definitely with lot of personal data that you're dealing with. This has to be a consent-based system. And then working with, on this platform, calling solutions, calling partners to partner with us, and bringing other novelties in terms of how can the platform find its full expression. And the life course integration, whether maternal health, adolescent health, NCDs, and so on and so forth, the emergency care, our 108 ambulances that we run, and the health screening platforms. So 71 lakh people we have identified through the NCD screening programs that Government of India has run, NCD 2.0, 3.0, for hypertension, diabetes. Today it is for oral cancer, cervical cancer also. And then for them having a treatment paradigm, reaching out to them every 3 months ki oksari wala to mana healthcare workers ni paminchi like aido oti cheskoni, ensuring that they are taken care of. So this is what is happening. I'll quickly tell you now the other part. Now, as part of this, we ran a MedTech Innovation Challenge also. I'm not shifting to full screen mode because I'll probably show you the MedTech Innovation Challenge also and the platform that has been developed. For that, we had given 6 use cases. We are already in a challenge, but I just thought what we've done in Government of Andhra Pradesh will show you. AI-powered diagnostics, point of care, smart wearables, telemedicine, non-invasive diagnostics, and prior health conditions-based solutions. And with that, we have set up a committee on advanced technologies. NHCX, Kiran has been a great pillar of support in terms of guiding us in terms of how to take things forward. And Vikram also has been helping now. So there are reference points also in terms of whatever we do, sir. So I'm thankful to CEO sir for giving us the opportunity to work with your two stalwarts in terms of taking things forward. And what we have done, sir, is essentially now, we have actually said that we will do a bounty of, we'll give a 1 crore rupee award to the winner and partner with them and say that we will give you population scale deployment in our health facilities. Apart from each of the use cases, the 6 use cases, we will have a 5 lakh, 3 lakh and 2 lakh award. And then whenever we are going for population scale deployment, we will actually become a partner with that startup and do a 1 crore rupee. It is like so it is akin to running a RFP process or a GFR. We have actually enabled it as a part of our government order also, that it becomes a part of a government procurement today. And sir, so what we have done is now deployed these also. Salsit, for example, has been deployed in PSC Rajanagaram. Sunfox has been deployed. This is a hard care management in government GGH Anantpur. Art Park is working with our real-time governance system. Cognitive is with the Government Hospital of Mental Care, Vizag. And Gen Robotics is with the KGH Vishakhapatnam. So like that, 20 solutions we have identified. And they have already been in a sandbox, physical sandbox environment, deployed in hospitals. Where, in fact, so and on a daily basis, if there are any found, so since they've been now almost working for 2 weeks now, so we have thrashed down the initial issues in terms of coordination issues or getting the right kind of environment or the right kind of champion on the other side also working from the hospital side. I'll just quickly, and so these are the 20 I'll just quickly show you the dashboard for that also. I hope I'm not exceeding my time, but essentially with the kind of audience that I have today, I thought that, okay, I think I'll take another opportunity only to showcase this. It does not seem to be there on my, or if I can actually. So this was the RTH. Yeah, okay, so this is the dashboard. We had, to the Committee on Advanced Technologies, we had given 92 applications. They were assigned to them. And they had these 10 evaluators. They had Dr. V. Ramanathan was there from ISC, Sangeet Verma ji was there, Dr. Shiv Kumar from Catalyst, and so on and so forth. Dr. Rakesh from AIG Hospitals, Dr. Sushila from Andhra MedTech Zone, and Suhela Kapoor and Mona Dugal from ICMR. So each of them actually in a model where we love doing challenges, because as bureaucrats we don't have to measure and evaluate. We can always call for the expertise from the sector, private sector, as well as from the academia which is available, and then do a very fair evaluation of the challenge also. And then what we specialize in is setting up the sandbox, providing data, and providing the physical sandbox also in a very frictionless manner. And through that, sir, we had actually looked at all the applications. They had evaluated the TRL level also, and for example, this is Mediotech, and then we had gotten all the video demos and all other demos. They had uploaded their own.
Hi, welcome to our overview of
I'll
our
not go through the detail, but
population for
essentially
diabetes and
we have
hypertension.
information on.
We
each
also
of
signed
the-
an MOU with
each
Tamil
of
Nadu
the
Apex Skill Development
proposals that
Center
had
for
come.
skilling
So
and
this,
training
sir, we run
frontline
through the
workers on
the
digital
reason
health
I wanted to
technology
showcase
using our
that also
4-in-1 digital health
that
platform.
we are using this Ratan Tata innovation of RTIH. This is our artifact. It is equivalent to the Startup India portal. But the benefit on top of that, the offerings are that we are making it as a procurement portal also. And we are saying that if you qualify through our MedTech challenge, so this is agnostic to the, so today we are using it for health department. I also handle civil supplies, sir. We use it for a video analytics or a CCTV or camera computer vision solution for the gunny bags or for my 250 odd mandal level stock points or the go downs also, and set up that. So we are able to use this Ratan Tata Innovation Hub very strongly to run all kinds of challenges, and we in fact urge IIT Hyderabad also to partner with us. We are seeking partners so that whenever we are doing a challenge, we can partner and collaborate and provide visibility to the startups, to our ecosystem, to our sandboxes, and offer them rapid deployment. Thank you so much for the opportunity, sir, and we look forward to collaborating further. Thank you.
Thank you so much, sir, for that comprehensive overview. We now come to the keynote address of this inaugural session. It is my privilege to invite Dr. Sunil Kumar Banwal, Chief Executive Officer of the National Health Authority.
Good morning and namaskar. Indeed, it's a big privilege to be present here at the NHCX Innovation Meet, organized by NHA in partnership with so many agencies. The IIT Hyderabad has been a key partner helping us conduct this 2 days event, has been helpful in evaluating the solutions which came. We have AHPI, India Insurance Tech, InsurTech, Nat Health, NRCS, and even Insurance Information Bureau, IRDAI, NABH. That shows the kind of interest the organizations have in NHCX. And I think NHCX, the foundation remains Ayushman Bharat Digital Mission, which Saurabh mentioned in detail. Actually, he has gone a step forward what we made in ABDM. Andhra will be probably the leading state which leverages ABDM for all its potential. So while we keep talking, we have created the digital public infrastructure. I think there has to be some candidate who leverages this digital public infrastructure to use cases for the benefit of the society. And I think Andhra Pradesh is going to be one such a state. And in fact, it's showing us the way how to procure many of the applications for, lot innovative solutions or applications. In fact, this challenge is going to come much more when we are thinking of procuring AI solutions for healthcare. And we know, we are seeing, it is already happening. The institutions know, the organizations know that there are many good solutions which are coming up. But as a government organizations, we all see huge challenge in procuring it for at population scale. So this is going to be a way forward which Andhra Pradesh is showing us, and probably that is the way to move forward in procuring innovative solutions. So I welcome all the partners, all the guests. I see huge audience from innovation ecosystem. We have industry partners, we have students, researchers, academicians, and these shows how such a topic of NHCX creates the interest among different stakeholders. Many will think NHCX works only for the hospital and the insurer. But if we go in detail, it actually works for whole health care ecosystem. And this is one area where every one of us are facing challenges. We saw many of the challenges can be handled by technology, but real address will happen only if everyone takes interest, looks forward to using those technology for making it solve some of our problems. So this is what we see. The biggest challenge which we also get in using new technology is the lack of awareness among different stakeholders. I think this is also one forum by which we are creating the awareness about the digital public infrastructure that has got created in healthcare. And I think the way, in fact, yesterday we were meeting the Chief Secretary of Government of Telangana, and in fact he was not aware of this kind of DPI which has got created in healthcare. And since it is a healthcare, each individual is going to be affected. And therefore, everyone wants to know it also. So it's our responsibility. How do we make it reach to everyone who can be benefited by this technology? So this whole idea of organizing hackathon on NHCX, though we gave 5 problem statement, the idea was also to engage everyone in this healthcare system to know about NHCX, to understand what potential it holds and how it can be leveraged to solve some of the pressing problem in health insurance. And this, I think we are to a large extent succeeding, because the kind of partners we got has been really encouraging for us. And I must also thank that in this hackathon, the participation level has also been very high. More than 400 registration we got. That shows there are people who are really interested in knowing what exactly is happening in this space. We saw more than 100 teams which actually participated and submitted solutions. In fact, yesterday I was interacting with some of the winners of the this hackathon, and in fact I was excited to see a lot of ideas come from their side. So we told about the problems. Many a times, even identifying problems is also coming from the innovators. So this kind of hackathon has actually ignited a lot of minds to think in this space, and I must thank all of them who participated in this hackathon, submitted their solutions, and those who have won the won in this hackathon prizes, which we will be giving today, and I must congratulate all of them. In fact, all the participants brought quite a good solutions. In fact, the next level of challenge which remains is how to procure those solutions. And therefore, what Saurabh was giving the idea of, putting 1 crore to make this deployed at a real case basis in the hospitals is something which is also coming to our mind, that how do we engage with these winning solutions. And some of the ideas do have come to us to engage those individuals or the organizations with NHA at a long-term basis, but at the same time also finding out ways how to engage them at population scale. And this, in fact, we got the idea from Andhra Pradesh, but NHA is also in the process of drafting some kind of SOP for deploying these solutions at population scale. Maybe initially we take the risk for a year or two to deploy, and if it succeeds to go for, by the time we also learn about the outcomes of those solutions as well as the costing of the solutions, and then we can go for a large scale deployment. So this is something which we are going to do with the winner or the winning solutions. So this, I think NHCX hackathon has been a great success, and all those who really helped us organize this must be congratulated. I must thank on behalf of NHA to those partners and participants. Thank you very much. Now, I think yesterday you had a good session on NHCX, and I think the level of participation I could see, there has been a good engagement with the all stakeholders. We all know healthcare system in India has been highly fragmented today. And the reason had been, the kind of diversity we have, the kind of, segregation we have. There is a challenge, and India probably is the country where participation of both public and private sector in healthcare has been quite mixed. In fact, more private sector participation is there in the healthcare. And therefore, there cannot be a unique solution which we can actually fit to the whole of India context. And therefore, we always keep on innovating based on the region requirements, and therefore states are also very important. So now moving from the fragmented healthcare system, what ABDM has created today is to provide us the opportunity to connect these fragmented health systems. And this, I think, those who have undergone some of the studies about ABDM will appreciate. This is something which we need to promote among all the healthcare providers and healthcare professionals, how these will actually help the create an integrated health system in the country. And besides this, with a country of so much of diversity, and also with so much of mixed participation of private and public sector hospitals, I think ABDM is a unique infrastructure which has got created, and through which we can actually connect the health system. With these registries which has been created under ABDM, whether it is ABHA ID, HFR, HPR, and the gateways like health and information exchange, unified health interface, and finally NHCX, these actually provides all the each of the health systems to talk to each other. Now by this, we have a unique way of connecting without migrating the information data. So while there is no central repository of data, but there is a huge scope by which we can have access to those data. There are ways by which there is a possibility of federated learning on the data. So this is something which not just allows patient to share the data across the health facilities, it also allows government and the organizations to use the data with consent for next level of research, which could be analytics, which could be application of AI, which could be application of any emerging technology for betterment or rather for predictive healthcare. So this is a possibility which has emerged, and I think in the India Impact AI Impact Summit, those who have participated must have realized that India has created huge data, but these data are quite fragmented, quite unstructured. With ABDM, we have created digital foundations, and we need to make this to be adopted across the health system so that we start creating more of the structured data. And with this federated architecture where we have access to the data, we actually deploy AI solutions on large variety of the data. In fact, in the AI summit, those who have followed must have realized we launched two major initiatives in the Impact Summit. The first was, it was open benchmarking platform for health AI. This was something which was based on the idea that any AI solution which is brought in Indian context must pass the test on Indian data sets, Indian diverse real data sets, and that data sets exist with the government primarily, whether it is with the AIIMS and the premier health institutions or under the Ayushman Bharat PMJ schemes. So this was the idea which actually helped us create this platform, which we are calling Bodh, and will help us actually test and benchmark the AI solution, and it will be very important before deploying any AI solutions at population scale. So that way this Bodh platform becomes a platform where we are able to test the AI models, and in due course, in future probably we can also develop our own AI models, because we will have access to the federated data in healthcare. So this is one initiative which we launched. The second was the strategy for AI in healthcare. This is for SAHI we are calling. This sets the framework how AI in healthcare will actually be used, which will be guided by the trust, evidence-based, and should be inclusive. So this strategy paper also gives us the idea and also actually promotes organization to think before using in any AI solution at large scale through their organizations. So while pilots are all fine, but if we want to use at a scale, we will have to be very much aware of the challenges it brings, whether it is a ethics or bias or exclusion. These are the things which need to be addressed through this framework which we have created. Now, coming to the NHCX, when I joined NHA, I was told we have this platform, and this got created because ABDM came in place, and we realized that this is something which is need. But at the same time, we find the adoption of NHCX is a big challenge. The problem is, on one side we have insurance companies regulated through IRDAI. Another side we have hospitals which are under the Ministry of Health and Family Welfare. More or less they are having also a lot of regulations, but not regulation for their businesses. So these are the hospitals who provide health care. And finally, between the two, there are patients who actually get the service and also pays for the service. And they are the affected ones, and therefore the government role becomes very important to actually connect the insurer and the hospitals to have a fair and transparent transaction. And that is why NHCX becomes very important. And in fact, the challenge of the health insurance sector is the sheer trust deficit we see between the hospitals and the insurer. And this trust deficit, finally, both are equally empowered, both hospital and the insurance company. The sufferer are actually the patients. And therefore, our role is very important to bridge this trust deficit, and that can be done only by the use of technology, which makes the interaction between the two highly transparent, very objective, and this is what we are trying to do through the NHCX. And this NHCX, we are trying to bring both insurance company and the hospital at the same platform. Maybe we are using Ayushman Bharat PMJ to leverage our capacity to actually prevail on them to come on NHCX, but finally it is every hospital and every insurance companies, and not just the insurance company, any insurer has to be on this platform, so that we actually build the capacity to settle the claims more objectively in a transparent way, which builds the confidence both for the hospital as well as for the patient. With this, I believe not just the 2 days, for last 3 weeks since we have opened the hackathon, there has been a lot of response. We selected particularly this place, IIT Hyderabad, for a SEER regions. Not just the IIT is so important, which has good ecosystem for research, for academics, but also Hyderabad, which is both, it is a hub for the hospital, it's a medical hub. At the same time, it is a technology hub. You have good tech companies. At the same time, you have good number of hospitals. If few good hospitals start using NHCX, I think there will be huge message going all across the healthcare that this is something which will actually change the way we hospitals interact with the insurance companies. Today, we will also hear the chairman of IRDAI who will be speaking what the challenge they are seeing from the insurance company's point of view, how those can be mitigated, how NHCX can be, managed something like we did for UPI, like NPCI does it, but hardly people know what NPCI is, but everyone knows what UPI is. And something will happen with our system also, where people need not be knowing who runs the NHCX, but they should all be aware that this system works well for them. With this, I also see there are needs that we get good number of agencies who become the ambassador for these initiatives. We started, I think, 2 months back in NHA, two programs, one as a program for NHCX champions, and I see there are organizations who have come forward to champion the cause of NHCX, become a champion to promote NHCX, and we will be recognizing them. And similarly, we have also started the ABDM ambassador program, who actually promote ABDM across the healthcare system through their members. And I see there are a good number of professional bodies who have come forward to become the ambassador for ABDM. With these two, we are hoping that NHA will trigger the interest among all the stakeholders in healthcare to actually use ABDM and NHCX to make the transactions convenient, empower the patient, and remove the trust deficit between the different stakeholders, more particularly between the hospital and the insurance companies. With these words, I hope this 2 days event and this last 3 weeks hackathon has been a big success, and with such participation, I am highly encouraged in NHA to take it forward in more aggressive way. We will be looking for many more ideas, and we will be always open to engage with anybody who brings new ideas and are ready to work with us. We already have a NHA volunteer programs for those who want to work on a volunteer basis for few months, few years. We get good number of people, and now with the gathering like this, we see not just the technologists, also people from the insurance sector, people from the other components of the healthcare. We will be looking forward to such volunteers to work with NHA and support us in the cause to make the healthcare system in India not just integrated, also intelligent healthcare system. With these words, I once again thank all of you for participation in this event, and I wish this a big success. Thank you.
Thank you, sir. I now request Dr. Banwal to present the dignitaries with a token of our appreciation and gratitude. Um, Professor G.N. Shastri. It's okay. It's okay. Yeah. No, not now. Later. Dr. Gyani. Shri Saurabh Gaur. I now request Professor Shastri to present a memento to Dr. Sunil Kumar Banwal. Thank you, everyone. We now move on to a very special segment of today's program, the Awards and Felicitation Ceremony. After a rigorous examination, we have the top 3 solutions for each problem statement. I now request Dr. Banwal to felicitate the prize winners. From the first problem statement, the first prize winners are Praveen Sridhar and team from SOPA Claims. Yeah. The first problem statement, legacy systems to NHCX aligned fire converter. The first prize winner are Praveen Sridhar and team from SOPA Claims. The first runner-up are Smith Gandhi and team from ArgueSoft. The second runners-up are Shivam and team from Mimansa AI. For the second problem statement, clinical documents to FHIR structured data converter, we have the first prize winners, Shri Vidya Bhavani and team from Health Attai. As the second prize winners, we have Girdir Rao and team from Achala Health. As the third prize winners, we have Amey and team from Health Ains. For the third problem statement, PDF to NHCX aligned insurance plan FHIR bundle. In the first place, we have Abhishek Nikam and team from ClaimSync AI. In the second place, we have Jayam Gupta and team from Consent Health Forge. In the third place, we have Fanindra and team from Tanu. In the first business use case problem statement, fraud management and detection leveraging NHCX capabilities, as the first prize winners, we have Avishek and team from Cream AI. In the second place, we have Vedant and team from Arogya ID. Next, in the third place, we have Nikhil Dhanwani and team from Autoflow AI. As part of the second Ideathon problem statement, optimization of claims processing, time and cost, leveraging NHCX capabilities, in the first place, we have Bharat Bhushan Arora. In the second place, we have Harshit Bhojne and team from Shovel Tech. In the third place, we have Sumeshwar Pandey and team from Abhim Tech team. Congratulations to the winners for their outstanding work. Now, as mentioned by Dr. Banwal, we would like to take this opportunity to announce two important initiatives by NHA for strengthening ecosystem participation. First, the NHCX Champions Initiative. Under this, NHA recognizes and partners with key industry representatives to drive awareness, adoption, and implementation of NHCX. We are pleased to recognize the first set of NHCX champions. I now request Dr. Banwal to felicitate them with a token of our recognition. I call upon Jaya Singh from Nat Health, I request Dr. Girdir Gyani from AHPI to come forward. And now I invite Prerak Sethi from the India InsurTech Association. We thank you for your continued partnership and commitment to supporting the vision of NHCX. In a similar spirit, we are also launching the ABDM Ambassadors Initiative. Through structured collaboration, ABDM ambassadors promote awareness, build digital capacity, and support implementation of ABDM across the healthcare sector. We are pleased to recognize the first set of ABDM ambassadors. I request Dr. Banwal to felicitate them with a token of our recognition. Dr. Umashankar Nambiar from Telemedicine Society of India. Next, I call upon Shweta Sharma from Doctors AI. Next, Dr. Devanand Kolothodi from Consortium of Accredited Healthcare Organization, CAHO. We extend our sincere appreciation to these organizations for their efforts. Finally, I would like to take this moment to recognize an important milestone in the NHCX journey, the NHCX PMJ Private HMIS pilot integration. Through this integration, we have enabled structured data exchange and claims processing for the Pradhan Mantri Jan Arogya Yojana through any private NHCX enabled HMIS. We are pleased to acknowledge the early technology partners who have successfully completed this integration, helping validate the approach and paving the way for broader ecosystem adoption. The three early integrators are, and I call them up on the stage to receive a token of our appreciation and recognition from Dr. Banwal, Vikramjit Sarkar from ChiroCare, Chirag Goel from Chikitsa, Chirag Goel from Chikitsa or Vigorous AI. Chirag might be running late. And then Dr. Nilesh Bhandari from Plus 91 Technologies. From Chikitsa, I call upon Chanchal, co-founder, to receive the token of appreciation. Chikitsa. We sincerely appreciate their proactive participation and technical collaboration in achieving this milestone. Congratulations once again to all the awardees and recognized partners. With this, we conclude the awards and felicitation segment. We will now break for tea for 10 minutes, after which we will reconvene for the panel discussion. Thank you all so much.
I'm sorry to intervene. I'll announce on behalf of Government of Andhra Pradesh also my colleagues Apparao and Sobareddy are there, and we are happy to engage with each of the organizations that have won here. We run our own health insurance program under NHA mother program, but we have our own program also. And we are also looking for HMI solutions for private health claim exchange. So Apparao, if you can raise your hand, and Sobareddy, and I also will be available over tea. Thank you so much.
you came with. We will be beginning in a couple of minutes, as soon as possible. We will now jump straight into our panel discussion on scaling NHCX in healthcare, benefits, barriers, and enablers for hospital adoption. This session has been organized in collaboration with NatHealth, one of the champions of NHCX. I welcome the esteemed panelists and invite them on stage. Mr. Naman Jain, Senior Vice President, HDFC Ergo. Mr. Ashokan Somu Veerappan, CIO, Apollo Hospitals. Mr. Vinod Raman, Group CTO, Quality Care India. Dr. Nilesh Bhandari, Digital Health Strategist, Plus 91. Mr. Chirag Goel, Co-founder, Vigorous Healthcare. And Mr. Nikhil Chandok, Head IT Transformation, Aditya Birla Health Insurance. This session will be moderated by Mr. Maulik Choksi, Global Director, Health Systems Research and Policy at Axis Health International. Maulik, I request you to take over.
Firstly, thank you very much, NHA, for having us here. And I think so I'm thanking on behalf of all the panelists sitting here. Before the session started, we had a very interesting discussion on how this session is going to go about. So this session, as ma'am said, is talking about scaling NHCX in healthcare benefits barrier, enablers, and hospital adoption. But when we look at this panel out here, it's not only hospital adoption out here. NHCX is kind of one of the three gateways of ABDM, interface, consent manager, and claims management, or NHCX. But when we talk about claims management, I think so there are 2 or 3 important stakeholders who are part of this claims management process. One, hospitals themselves, who are the providers of system, who are a provider of healthcare. Then you have got insurance company, right, who are going to kind of reimbursing hospitals based on agreed benefit package and reimbursement rates. And third, we have got digital healthcare companies who act as a connector between hospital as well as the insurance company. So we are happy to have panelists today who represents all the 3 sections of NHCX, from hospitals, from insurance company, and from the digital health solution providers who act as a gateway between hospitals and insurance reimbursement companies. So, and these include Nikhil, Naman, Ashok, Vinod, Nilesh, and Chirag, representing each kind of segment of NHCX. And how it's structured, the panel structure is as follows. I have an open-ended questions for each of the panelists. I'll request the panelists to kind of share something about the work that they do, follow with the question that I've asked, respond to the question that I've asked, and I would request them to stick to 5 to 7 minutes, because we have got 55 minutes allotted to ourselves. And after first round of questions, we would like to open to the audience to ask questions. If there are no questions from the audience, then we'll go back to the panelists with the set of other questions that we have for them. So thank you very much, gentlemen, for being here. And I'll start my questions with Nikhil. Nikhil, I think so, again, when we talk about NHCX, insurance companies are going to play a very, very important role. So in terms of NHCX, what are the must-adopt infrastructure requirements that an insurance company needs to have, and what is the real value that it will create for insurance company?
Sure.
Thank you.
Thanks, Maulik, for the question. Thank you, everybody, for being a part of this discussion. I had technology transformation for Aditya Birla Health Insurance, and as part of my role, just a quick introduction, I look at how do we engage with hospitals, with providers, with a lot of the other ecosystem partners in the claims fraternity to ensure that we give optimal and best experience to our customers, to our stakeholders, to policyholders, etc. Right? So as part of that, Maulik, from your the question that you asked about the infrastructure, and see, the way I'd like to put this is, we don't necessarily look at Aditya Birla Health, right? We don't look at NHCX as only a compliance mandate coming from a regulator perspective, right? I think we are completely bought on to the journey of NHCX. We think it's an extremely powerful platform that is going to change the entire ecosystem and the way interactions happen between customers, between hospitals and the insurance companies. In my mind, there are 3 big pillars, right, which I would say is going to enable this entire transformation, right, for adoption of NHCX. Number 1 is, I think, transparency. Today, what the challenges we face as insurers is we have to integrate with different TPAs of the world, DHS of the world, and different hospitals providers, right? So the kind of effort that we do in these integrations with all of these stakeholders, it impacts a lot of time, effort, cost, and that is something which we feel as an insurance company is something which is going to completely change on the onboarding of NHCX, right? So that's number one. The other bit specifically is about standardization. Right? Today, because of multiple integrations we have, every hospital for that matter, we integrate with different data points that come in with them. The TPS come with different data points. We don't have standardization of EHR, PHR, fire standards. So these are elements which we feel that if there is standardization that comes across and NHCX as a platform is able to enable this integration that comes in from our external ecosystems, would fasten a lot of claim processing at our end. Right? So today, when a customer gets admitted and a patient gets admitted to a hospital, he's told, "Aapko, I mean, pardon me for the language, आपको 5 या 6 घंटे शायद wait करना पड़े because claim processing will take time." That is the experience we are trying to change at Aditya Birla as well. And NHCX as a platform is a big enabler that we see in today's context, right? The third part is specifically about claims, right? Fraud of claims that we come across at times, right? So a lot of this transparency and standardization will help us do a lot of analytics of customer data, customer behavior, any unforeseen situations that come through. So these are three big pillars in my mind which will help to stabilize and increase the penetration and standardization across the provider, hospital networks, and the insurers. More so from interoperability perspective, how do we interoperable between the entire ecosystem? That's what I feel. Maulik.
I think so. I think so. It makes a lot of important point in terms of bringing transparency, in bringing of faster claims, in terms of fraud management. But let me come to Naman. I think so. These are some of the integral goals that even NHCX or ABDM wants to achieve, right? Faster, transparent claim processing. But and that would help that if you got systems where auto education starts happening. I think so a lot of things could happen. But what are the operational risk constraints currently make insurers cautious about this rule-based system that we are bringing in as part of NHCX and where this ecosystem get evolves? When the rules-based system, what are the operational challenges that you think that you will face as part of HDFC or larger insurance company?
Okay, thanks Mehul. Good afternoon all. Just to give you a background, I am Naman. I take care of the hospital network at HDFC Ergo General Insurance. We are one of the leading insurers, and the efforts have always been to move towards technology, take support whatever best way we can to make customer experience better, and obviously taking care of the risk that we carry. Thanks Mehul for the question. I think risk is one thing which we are trying to ensure. And while we process health claims on a day-to-day basis, I think we are at a risk wherein we may get cheated at some point while we are processing the claim. At the same time, yes, there are a lot of regulatory interventions coming in on and off, which are taking care of the customer's benefit, be it related to the turnaround times that are required while processing a claim, either at a initial intimation stage or at a discharge stage. So all these things are very, very critical for us as insurers, wherein we are proactively trying to reduce down on the time that we are taking while processing claims. Having said so, there is a probable risk. While we move with speed, obviously the risk also increases, and so in healthcare. As Nikhil was also talking about, we are right now a very unstructured kind of a ecosystem that we are having between healthcare providers or insurers. So to say, the non-standardization happens at the very basic, wherein the tariffs for each hospital would be looking different. The bills that we receive from each hospital would be in a different format. For us to integrate everything and then to come up with a rule-based solutions becomes tricky. There have been certain instances wherein we as an organization or industry as a whole rather have tried a lot of rule-based approvals. It is still simpler in a few kind of specialties when we talk about cataract as a procedure, right? It is relatively simpler wherein we can put a rule-based processing. When we talk about maternity, it is relatively simpler wherein a rule-based processing can happen. But typically when we talk about risk, there are two kinds of risk. One, the non-medical risk, and the other side is the medical risk. Non-medical risk is something which we can still take care of, manage with a lot of intervention of AI and technology. NHCX has been a good enabler, wherein it can add a lot of value to the entire process that we do right now. But due to the non-standardization of basic infrastructure at the hospitals and between the insurance companies, it becomes little tricky even to manage our processing on a auto adjudication mode for the non-medical related expenses. However, when we come to Medico, it is something, even if we put technology at place, then also human in the loop will be required, because it is not necessarily, so we process claims in an office which could be 1,000 kilometers away from where the patient is being treated. And treating doctor knows as to what is happening with the, what is the actual condition of the patient, what are the practical challenges that he's facing with the health of the patient while they're treating. While we process it based on certain documents that come to us. And again, since they are not standardized, we have our own interpretation, which leads to a lot of back and forth. So the risk while we do a processing, and if we put our total dependency on automation, the risk is that we may end up paying more. We may end up paying for an illegitimate claim. There could be certain pre-existing diseases which could be there in a particular with a particular patient, which could not have been disclosed at the time of sourcing of the policy. We may end up paying those claims if the system misses those. So a human in the loop is required while we consider the medical side of adjudication. But yes, technology is helping us. We as an organization and industry as a whole is trying to adopt a lot of new technologies. We are trying to enable our systems in a way wherein the basic non-medical adjudication happens automatically, so that we don't invest time while processing a claim. As Nikhil started with that, एक normal statement होता है कि when our discharge is suggested by a treating doctor in the morning, typically it will take, a mindset is there that will take anywhere between 5 to 6 hours. Though regulator says 3 hours, but that 3 hours starts when the document hits the insurance company. Before that, there are a lot of activities which are happening at the hospital, and also they need to generate a discharge summary, they need to finalize their bills, they need to take clearances from all the departments. So risk is there for cost to sum it up. And yes, we are very vigilant while we are processing. We want to be empathetic to the end user. We don't want to end up denying any claim or raise unnecessary queries, because that creates a lot of problem. Cost is one risk which certainly comes at the epicenter for us as insurer.
I think so. Thank you very much, Nikhil and Naman. I think so. Both of you have touched upon one of the core kind of problem statement that NHCX is trying to address is standardization of documents in terms of the summaries coming into it, and with envisaging that currently the turnaround time around 46 days could come down to around 22 days or 20 days as far as efficiency gains are concerned through auto education, and making sure that there is standardization in terms of cost parameters, there is standardization in terms of how they are presented to insurance company. But going to Ashok, I think so. What Naman recently mentioned, I think so. A lot of things also depends upon the time taken depends at a hospital level, right? In terms of time taken for insurance claim to happen from 6 hours to 3 hours, and you are part of a large hospital network like Apollo. So what are internal investments, technology changes or adoption you need to do, or would you need to do to bring such kind of system as part of your ecosystem?
Hi, okay, thanks. Thanks, Maulik, for the question. Namaste and good afternoon, everyone. Thank you for having us here. That's an interesting question, Maulik. The process evolution has been the core of the healthcare industry for quite some time now. Gone from those days of where you actually process data from typical papers to systemic entries today. From a technology investment standpoint, it starts right from the beginning of how do you identify a patient itself and how do you validate the identity. So all the way from that particular point of identifying a person and how do you complete a care and how do you kind of ensure that the reimbursements of cares are done. So the technology investments goes across at least 7 to 8 workflow processes streams that we have kind of enabled. From a actual system investment standpoint, what I would want to say is there's a large set of communication systems that we have built, which would kind of act as intermediary layers between us and the insurance or the TPA processors for various levels of transactions that we do with them, be it for initial pre-auth processing or for the enhanced processing during the course of the care and at the final discharge claim processing. What we have also built in along the way is to kind of build in checklists to kind of manage each insurance requirements. I think that's one area where we could help. We could get NHCX to standardize and say, okay, these are standard, checklists that we need to follow across. So pruning up checklists for each insurance providers or each policy makers is going to be an important task that we kind of achieved quite some time. And we've kind of made our submission timelines from upwards of 45 plus days to today, less than 15 days today. So, so that's the kind of significant change that we have brought in based on the technology investments that we could make. In fact, with the NHCX systems way back in 2022, if my memory serves right, we did the first sandbox testing of our applications. So it's a forward-looking thought to say, how do I simplify communication of information across the ecosystem, not between one or two providers, across all ecosystem by eliminating waste and making sure the people are put in for the right set of processes. And I think, and that's the fundamental, the magnetic attraction between both of us on this platform. And I would welcome to make this platform more successful.
I want to ask one more question to you, Ashok, on this. You did mention about the processing between insurance companies and your hospital, but within hospital, right? I think so. The pain point also may exist at the time taken within hospital to get those claims ready. So, what are the? Can NHCX support in those kind of efforts, and how you as an entity are looking into reducing that time taken as far as claim processings are concerned?
There are two or three things that we do. What we do is, one, in terms of just-in-time transaction management. How do we kind of put in relevant set of entries that would come at that particular point in time, so that the amount of queries and denials that you would get, or a number of iterations that you go through, are minimized as much as you can. If your enhancement top-ups are right, then the discharge queries will be much smaller. So how do I do those iteratively over a period of 5 days stay? If we could get that process more standardized, then it will become much more easier and faster at the end when the discharge makes happening. So what we actually look at is, we kind of take the logical cycles of operations that happens, right? Day one, when you admit, you have all your pre-op checklist that you do. Post-op, you get some amount of changes. So we kind of create those process milestones and figure out, at this milestone when happens, what kind of quick transaction turnarounds that you need to have, so that the billing, etc., becomes much more amenable and amiable. And then you keep discussing with the patients, keep discussing with the insurers, make your top-ups done, make your documentations done, and preempt those documentations upfront. We have a process where we kind of create discharge summaries from day 2, keep appending transactions that keep happens every day, and then the final day discharge summary time becomes a little bit smaller. The most of the time that we take today is between medication reconciliations of inward versus consumption, and that is something that we need to automate a little bit more than the actual time would compress.
Thank you very much. Let me go to Vinod. I think so. What Ashok did mention was within an ecosystem, right? But when we talk about insurance, when we talk about interoperability, it's kind of multiple similar kind of entities come together. So what Ashok did mention was, look, we can do it. But when we talk about multiple entities coming together, and when we talk about interoperability, are we somewhere kind of decreasing the importance of complexity or integration out there? Do you think that these processes are more complex than they seem to be?
Good afternoon, everyone, and thanks for having me here. Thanks for the question, Malik. I think your question is very layered. Just by way of background, I lead technology and digital at Quality Care India. Quality Care India itself is composed of 3 distinct hospital brands. There is Care Hospitals, which is headquartered in Hyderabad. There is KIMS Health, which is headquartered in Trivandrum in Kerala. And there is Evercare Hospitals, where we have 2 hospitals in Bangladesh. And the reason I bring that up is that the heterogeneity of systems that run these hospitals is kind of testament to the fact that there is no standardization, right? And the nerve center of a hospital is the hospital information system or the hospital management system, the HIS, HMIS, HMS, whatever we might want to call it. And most of the data pertaining to the patient, the master data, most of the data pertaining to billing, most of the data pertaining to the clinical procedures that the patient has gone through, most of the data that is required for claims processing sits within the HIS while it has to integrate with 1,000 other systems. NHCX is a fantastic step forward in terms of attempting to streamline and standardize processes for claims processing. But the challenge is broader and deeper. It's broad because of the sheer heterogeneity and diversity of systems that typically hospitals run on. Many of these HISs that we speak of are legacy HISs, right? Some of them may or may not be fire and HL7 compliant. So which adds to that complexity, which means that we will have to write custom code, custom connectors to pretty much have any two diverse systems talk to each other. NHCX attempts to bridge that gap, but still the limitation is the very diverse systems that are used within a hospital. Now, to a third party, this might seem like, "Arey, isko to hum log API se solve kar lenge," right? So that's a very easy way of putting it, but that still underestimates the complexity of the lack of data standardization, right? The data models, data formats followed within each system are very unique to that system. Some systems don't even have the capability to expose APIs and services. So which means, how do we handle integration with that system? Thirdly, with the evolving landscape of cybersecurity and cybersecurity compliances, like for instance, DPDP, which started in 2023 and which was crystallized in 2025, the compliances, the regulatory requirements surrounding sharing of data, sharing of consent, also add to the complexity of integrations. So these are all problems to be solved. Can NHCX solve all those problems? Not yet. Can hospitals solve these problems with NHCX? Not yet. But do we have a way forward? Absolutely, because this is the first step in the form of standardization. And this is the first step where we are saying that the systems that the hospital runs should become compliant in terms of how they store data, how they share data. So we are probably about 3-4 years away from saying that we are at a state of maturity in terms of leveraging the full value of NHCX.
But again, when you've got a 10-bedded hospital or 20-bedded hospital, right, it's also an investment case. And again, the question that I asked to ask you, because that's an investment case that they have to make for themselves, right? And in this fragmented, heterogeneous kind of ecosystem, what further could be done for them that they get onto this platform, and as well as insurance ecosystem you're talking about?
Right. So there are two things that have already happened, which are steps in the right direction. One is the creation of an ABHA ID, right, where the attempt is to democratize, from the patient's perspective, access to healthcare, and from the hospital's perspective, to get information about the patient which is relevant and which the hospital can use in terms of giving the right sort of clinical outcomes for the patient, right? Again, ABHA is something that is, while widely adopted, is limited by the amount of linking that has happened with the medical records. So successful adoption of ABHA means successful interlinking of medical records. Successful interlinking of medical records is the first step in terms of getting full visibility into the patient and the clinical aspects of the patient's journey with multiple hospitals. The second part is where we need to have data pertaining to that patient translating into the procedures and surgeries and the daycare and whatever they go through. And then that then flowing into the claims processing. Claims processing historically was a manual effort where we had to have an army of people in terms of collecting all the paperwork, potentially scanning, and then uploading these to the relevant portals. And there is a plethora of TPAs, there is a plethora of insurance providers, there is a plethora of government schemes, and each of these had a separate portal. So NHCX is trying to bridge that gap. The prerequisite to this is having standardization. So part of the NHCX, the ABDM mandate, should also be to provide the mechanism for standardization. One of the mechanisms for standardization could also be enforcement of certain standards that these systems need to provide, right? And part of that can be enforced only if there is a certification that these systems have to undergo. Because ultimately the ecosystem, the 360-degree tying in of the ecosystem will happen only if the systems that these hospitals use support NHCX, support ABHA, support the underlying protocols.
Thank you very much. I think so. What I'm hearing from both insurance colleagues and from is how crucial standardization is in terms of interoperability. And you did mention about that API might not be a straightforward approach of making them ABDM enabled and making sure that data transfer from A system to B system. Let me go back to Nilesh, right? Nilesh, you know, in a pre-session discussion, you did mention about doing similar kind of work in sub-Saharan Africa, having entire country Ghana adopting a kind of digital ecosystem, a state in Tripura, state of Tripura having done a lot of things, and state of Bihar. You know, how would you address this issue where there are kind of certain kind of ecosystems players whose systems are not in a form where API could also be integrated, right? They're in so nascent or still so immature stage. In that, how we can ensure that the ecosystem, and I'm talking about the digital service providers kind of narrative, how this could be kind of galvanized so that there is a faster adoption of ABDM and faster adoption of NHCX across different genres of hospital. I'm sorry, I've changed the question a bit.
That's okay. That's okay. I'll take this. I'll take this. So, Maulik, thanks for having me here. My name is Dr. Nilesh Pandari, and I represent Plus 91 Technologies. Happy to say that Plus 91 Technologies recently just got the certificate for being an early integrator with NHCX. So, we also are early integrators. Thank you. Thank you. And like you mentioned, we have been working with public health across Bihar, across Ghana, and like many other places in India. Yes, adoption has been slow earlier, but before I go on to the adoption part of it, I wanted to string it together what all that we have been saying. We've been talking about facing issues like data quality standards, no standardization. This is not something we learned from NHCX. This is something we have been seeing for the last 40 years. This is something we have been talking for ages. I quit, so I'm a pathologist by education, and I quit medicine after 10 years of practice in around 2005, 2006, and I shifted to technology. Then the first thing which I learned when I came into the field was data standards are not being followed. There is no standardization. That again was repeated in 2010, 15, 20, and now 26. So this is not a new issue that we are facing. The only thing right now is I'm more hopeful that this can be solved because earlier there was no incentive to standardize the data. Now at least we have this financial hook that you get reimbursed if your data is standard through NHCX. So this is the first time I've actually seen there being a financial incentive to adopting standardized data. So I'm very happy with that, and maybe also with the use of AI and all the hackathons that we saw, they have shown us ways where legacy systems, where you can use the legacy system data, PDFs, Excel, whatever format it gives you, and convert it into file bundles. So these kind of innovations is I think what will actually stir out the adoption. Asking hospitals to totally shift from their old legacy systems and come on to ABDM compliant systems is just not possible. Many hospitals would just not do it. So these hacks that we saw over the last day, where you build in a connector between legacy systems and NHCX and spur the adoption, I think it is very good. On the other hand, like you mentioned, there are some hospitals which have very, very basic IT, and for them, moving on to NHCX is going to be very difficult if they continue to use the software that they do right now. And here is where I think what was mentioned earlier in the morning, that capacity building is going to be very important. We are giving incentives. So also another thing I wanted to say is, Dr. Gyani had mentioned in the morning, DPI, what we have in India right now, this is not the first time that we have created a DPI in NHCX. DPI has been around for 10, 12 years at least. We have been working. We already have a playbook. We introduced UPI, scaled it up. We introduced GST, scaled it up. We introduced ABDM compliant software, decently well scaled up. Why? Because we already have a playbook. We come out initially, there are some incentives. People are asked to come onboarded. Then we get the software companies together, ask them to integrate that platform into them. Then once the adoption has been slightly seen in the market, there are enough players producing that adoption, that is when you start creating those mandate nudges. So this playbook is already created. We are not going to discuss and find something new. It's there. And that is exactly what is being followed right now. We started off with incentives, 500 rupees extra per claim. Then we got now these early integrators. The next step is going to be get more integrators. So once you have, say, 15, 20, 25 HMIs giving this particular NHCX integration, then you'll have the slight mandate nudges. So I think this playbook is already created, nothing new I'm going to say. We have to just learn from what we have already done and put it here for adoption to happen.
So thanks, Nilesh. And what I'm hearing, and I think it's a very optimistic statement that you're giving, that there are already processes and pathways that have demonstrated scaling up of similar interventions. And if you look at NHCX, I think it's the right direction where even a small nudge of 500 rupees incentive can further take faster adoption. I need to go to Chirag, but I think so still I am not clear on the smaller hospital front, right? Where there is almost nothing is existing. So for them to get onto ABDM platform, getting NHCX, right, they need to have human resource investment, they need to have skills, they need to get workflows created. You know, what in your experience is a way forward that we can disrupt this inner or legacy of non-digitalized healthcare provider ecosystem?
Thanks, Malik. Thanks, NHA team also for this panel. So, Malik, firstly, I'll introduce myself. I'm Chirag Goyal, co-founder of Vigorous AI. We are into, we have multiple AI solutions for healthcare HIMSs, PACS, LIMS. So I'll just come to your question that what kind of these problems are coming into the small hospitals. I'll say less than 100 bedded hospitals, which are like small and mid-sized hospitals. So as I think Vinod from CARE and Sir from Apollo also mentioned that they have very much standardized systems internally also, the processes they have, which they follow to streamline the things and cut down the timing for the claims or multiple other things they are having the processes. But less than 100 bedded hospitals, they face totally different kind of challenges, which I have seen. Like they don't have any problem in the adoption of ABDM, but what they are struggling with, majorly they take care of the patients which are from the government policies, most of them, right? Either they are from the Ayushman Bharat or they are from any policy which is issued by the state. And they have their own card, that is in Rajasthan like Bhamasha card or Jan Aadhar, or in Goa if you say DDSSY, something like that, okay? So that hospitals wants to take care of that first, because they are saying that our patients have that card and all the treatment which is going to happen, we need to map with this ID. They are not currently ABDM enabled. So where they need to send the data, still they are saying that our systems are not taking the ABDM, they are taking DDSSY or they are taking Jan Aadhar card. So that is one of the challenge which they face. Second thing is on the claim processing side. Majorly hospitals which are less than 100 beds, they have outsourced their TPA desk. Okay, they have outsourced it to a company which is managing like 50 hospitals. The person is also not the employee of that hospital, it is hired by that company and they are following their own processes. Okay, so what is happening sometimes, which insurance companies are also facing, might be Naman and Nikhil can answer this later also, that they are facing duplication in the bills, they are facing that kind of, because the people are just, they are not just validating, they are just sending whatever the data is as it is. And sometimes if the data is not present, they are taking any data and sending it. It is also coming it. And how AI is now taking place, that in the fraud detection and all these things. When NHCX is coming into the picture, everything is going to be standardized and like all the data should be in FHIR structure, all the HI types should be mentioned, that data should be having these all parameters at least before you want to go for eligibility check or pre-auth. So these things are currently taken care by the people who don't even understand what insurance process is. They understand that how just they need to scan the document and send it over the mail to this email ID, or they need to log in this portal and upload the documents. That's it. Sometimes they are uploading wrong documents, means patient is different and documents are different also. It is happening. So the main thing is in less than 100 bedded hospitals, they need, if we want to penetrate NHCX and these kind of things, definitely incentives are going to help better. But one more thing which is kind of the knowledge, awareness that how it needs to be done, how it needs to implement in a proper way will play a very important role. Like ABDM, many hospitals have now started adoption as government is pushing it very good way. So they have started ABDM, but still what they are doing, they are just making ABHA most of the time. At the record linkage time, if you will see, most of the time doctor's prescription is not linked to the record. Pharmacist is doing entry and that is getting linked to the record. So doctors are also like taking kind of, it will increase their accountability kind of thing also if they are coming into this digital. So I think in small hospitals, it is like awareness as well as incentive will play a very good role in the adoption. Costing is not that barrier for them because they have already outsourced the desk. Okay, so costing is not going to make that much difference for them because they are already using some at least billing kind of solutions. But yeah, soon if they will start implementing and doing digitization of the medical record, it will help them and as well as to the insurance companies.
So thanks, Chirag. But what I heard from you are two important things. Firstly, there is on this panel, we have got one important stakeholder missing is TPA, right? Who has got a very significant role as far as when we talk about small or medium hospitals, and they have a huge role as far as adoption goes, and we are missing them as part of this call. And second important point that you made is schemes which are at state functional, which are not ABDM enabled, and I am sure that those things are getting ABDM enabled, but at a smaller level, when a lot of things are going on those fronts, those needs to be ABDM enabled for to complete the continuum pathway or at least the care pathway that we are talking about, right?
Correct. So all the corporate hospitals majorly take care of the private insurances. Most of them, they are empaneled with all the insurance private companies. But the hospitals which are less than 100 bedded hospital, their revenue is 70% relies on the government policies.
Support health insurance.
Okay, so that's and we know that majorly patients goes to less than 100 bedded hospitals. Corporate hospitals very means limited population goes. So if we want to push it very hard, then we need to take care of less than 100 bedded hospitals in a very and it can be possible when the state policies or state insurances are ABDM empaneled.
Yeah. Thank you very much. I think so. I have been given time warnings. I have been given a couple of times. But as promised, the first round of questions are done, right? And I see a hand out there as far as a question from audience is concerned. Sir, I don't know if you have a mic out there. We have got another question out here also. Anyone? We have got mic out there?
And there is a distinction that's made there between the use of data for primary care purposes and non-primary or secondary care purposes. So perhaps, and the question is to anybody in the panel here, could you please help us or clarify this distinction a little bit? For example, my naive understanding is that underwriting as well as adjudication will primarily, should easily fall into the primary care processes, which means you may not need consent in the first place. What would be other workflows in the claims processing or whatever you want to do with that data, the claims data, that would be called secondary use cases where consent would be mandatory.
Nikhil, Naman.
Yeah, thank you for your question. Very interesting indeed. In fact, just before this this panel discussion, we were having a chat outside about the entire implication of DPDA into sharing of data between hospitals and through NHCX and to the insurance companies, right? So let me give you a scenario, right? A customer goes to a hospital, right, for various other reasons, and all the details, patient history, clinical records gets recorded on the system. That information gets passed on via whichever medium, right, through through the connectors that we just talked about. Could be API connections that goes through the NHCX platform. So essentially what's going to happen is, let's say that data comes to the insurance company in encrypted form, right? So it's a public-private key which is there with the hospital and with the insurers, right? So NHCX may not have visibility of the transit data that comes through to an insurance company. That's number one, right? Second would be specifically, it depends on the patient, right? From a consent standpoint, of course, the data for processing his claim is primary data, right? Is the primary consent that we take from the customer. Now that data, once it reaches the insurance company, if that data is to be used for any promotional activities, that is something which is not allowed in my view, right? That is something which requires prior consent from the understanding that we have. The policies out there, a lot of us, including all the sectors across, so it's not limited to only insurance or hospital, right? The act is for the entire country across is what we understand. So specifically, that space is evolving. Each organization today is trying to ascertain and decipher which of this section falls in the best interest of the customer. So I don't know if I've answered your question. In my view, it does, because when you look at, for example, Abha ID as well, right? So we are talking about unified EHR and PHR data for customers, right, in a central view. So as an insurance company, for us to faster underwrite policies, faster payout claims, and also ensure that there is uniformity of customer information across at one particular ecosystem. That information is very crucial to us as an organization, right? So for instance, if I have to pay out a claim, right, I will have to look at, the entire historical evidences and data of the customer, what is available on the platforms available. So for instance, if a patient raises a claim from one insurance company and goes to another insurance company, today there is very limited amount of data or interoperability is the point that we talked about, right? How do we get access to that information and use that information to ensure that it's in the best interest of all stakeholders together, right? So in my view, I think it is covered as part of the acceptable norms of the Data Privacy Act. But of course, nothing on other promotional is not covered. That requires explicit consent in my view. And Naman, you want to add something?
So in addition to promotional activities, we are also, as proactive insurers, doing a lot of things wherein we can try and improve the overall health of our claimants, right? So we would be underwriting X number of policies, but claims would be happening to about a percentage of that total volume. Now, we do initiatives wherein we try and drive diabetes awareness among certain policyholders who may be suffering from diabetes and are leading to certain claims in their history. So we try and do a lot of activities wherein we engage with third-party providers who are expert in their field, and we would like to pass on the data to those providers. So therein we get restricted because of the DPDP Act, wherein the consent becomes very important for us to be taken. So we are trying to find ways wherein we take a consent beforehand and then we pass it on to the providers. But then yes, to create awareness on the health, post-cancer programs are there to improve lifestyle of lifestyle and the life for the patient who has already undergone certain treatment. So these kind of challenges are there with us as insurers, wherein we do need consents at a later stage as well. And yes, that remains to be a challenge.
So you can have this conversation offline. I need to wrap it up.
I won't take more than 30 seconds, and I think it's a very important rejoinder. So DPDP Act 2023 applies to personal data. And just throwing this out there, if you can do an effective anonymization, then it effectively doesn't remain personal data anymore.
Thank you. It is. I'm hearing a positive note from Vikram, so it is. So we'll take that as an answer. So a question from a sir, and then we'll wrap up the session. Thank you.
I'm Pankaj Saxena from Health Smart Tech. So typically, if you look at any business, you always try to ensure that you protect your clients, right? And in small hospitals like 10 to 30 bed hospitals, the clients are their patients. They don't want the patients to be lost to another hospital, right? So that becomes a deterrent in actually doing interoperability. I mean, the moment these hospitals come to know that if they become ABDM compliant, they also fear that my client is going to go to another hospital and that data will be shared. So we have to break this problem into some kind of a solution. I don't know if it is practical or not, but if there can be an incentive for every time a data is shared from my silo system or my system, I am incentivized. In which case, becoming ABDM compliant becomes more meaningful, because even if the patient is going to another hospital, and if they pull my records, I'm still going to be rewarded for it. So that is one. And second is, whatever incentive schemes we announce, this is for the policy makers, that should be little long term. It should not be, fits and starts. It is valid for so much time, another, so many months and all. I mean, it should be like 5 years. So when I go and sell a system, I can go confidently say that if you become ABDM compliant, you're going to get this benefit for next 5 years. So that's my suggestion.
Sir, on the second point, sir is sitting here, so I think so he has taken a note of it. And on the first point, I think so, sir, when you talk about data, I'll quote a paper, and it's quoted widely in our health system research, right? A paper by Jishnu Das, that a patient to have an appropriate care have 7 touch points. So as a patient, if my healthcare provider is providing me enough information, I don't think so this interoperability thing even gets into his mind. I think so it's a quality of care from a provider perspective is more important. And the digital health incentive scheme does incentives on linking record, right? So when you link a record, you do get incentives, but the point well taken that in the duration of that DHI is very, very important as far as sustainability and motivating people is concerned. I am sorry, colleagues, there are a lot of other questions, but we need to wrap it up. So I'll just paraphrase what we discussed. I think so NHCX as a government initiative is in the right direction, number one. I think so it helps in a standardization of the way claims processing is going to happen, and it will decrease the time and increase the operational efficiency. But I think so, and there could be certain kind of things that could be done at a provider's level, which can decrease the time in terms of the time taken in creating discharge summaries and kind of stuff. And for a lower hospital, I think so incentive schemes could be really, really helpful in kind of making kind of NHCX a viable long-term strategy. And from what I also heard, that is something that we know how to do it. I think so it's just going to take some time in doing it. But with this kind of take-homes from the session, I thank you very much for being there and answering questions. And thank you for raising questions from the audience as well. Thank you very much.
Thank you.
Requesting everyone to please remain on the stage. Thank you to our moderator and our panelists for an insightful discussion. On behalf of NHA, I extend our sincere thanks to the moderator and all the panelists. As a gesture of appreciation, may I request Mr. Maulik Choksi to kindly present tokens of appreciations. Mr. Naman, Mr. Nikhil, Mr. Ashokan, Mr. Vinod, Dr. Nilesh, and Mr. Chirag. Thank you, everyone. I now request Mr. Nikhil Dongari, Director IT NHA, to kindly present a token of appreciation to our moderator. Thank you all. We now move to the final panel discussion of the NHCX Innovation Meet, centered on the future of claims from manual to digital first. As the healthcare and insurance ecosystems continue to evolve, the shift toward digital first claims processing will be critical in enabling faster, more transparent, and interoperable healthcare financing. I would now like to invite our esteemed panelists to kindly join us on stage. First, I invite Dr. Sunil Kumar Banwal, CEO NHA, who is leading the implementation of Ayushman Bharat PMJY and Ayushman Bharat Digital Mission. Next, I invite Shri Saurabh Gaur, Secretary, Health, Medical and Family Welfare, Government of Andhra Pradesh, who has been closely involved in strengthening health systems and digital health initiatives in the state. I now invite Shri Manoj Chatlani, General Manager and Head of Department, Health at IRDAI, who plays a key role in shaping regulatory frameworks for the health insurance sector. Next, I invite Shri Satish Kidugu, Chief Executive Officer of MediAssist, one of India's leading health benefits administrators. Now I invite Dr. Devanand Kolatodi, Chairman of KAHO, Telangana, representing the healthcare provider's perspective in strengthening quality and patient safety. I finally invite Mr. Tirtha Chatterjee, partner at Boston Consulting Firm, who works extensively on strategy and transformation across healthcare and insurance ecosystems. To moderate this discussion, it is my pleasure to invite Ms. Malti Jaswal, advisor at the National Health Authority, who holds extensive experience in the health insurance sector and policy ecosystem. She has been closely involved with NHA, working with stakeholders across the ecosystem to strengthen health insurance systems and advance universal health coverage in India. With that, I hand over the session to Ms. Malti Jaswal to lead the discussion.
Good afternoon, everyone, and very warm welcome to this session. My privilege to moderate it, but before I start, I request Dr. Banwal to set the context and share his opening remarks. Thank you, sir.
Thank you very much. Actually, let me thank for organizing this panel. The panel discussion, which is centered on the future of claims from manual to digital first. The name itself suggests how do we move from manual to digital. And since till the time we move completely on digital, how do we go on digital first? And this is something which is very important. As has been the discussion in the previous session and also during the inaugural session, we have understood how this NHCX platform has been created. So if we see, this is not just a platform. It also builds the capacity to objectively and in a transparent way do the transaction between the provider and the payer. This is something which works very objectively in a very standardized format. So the records which gets moved from one to other is in a proper format, which we call FHIR bundles. But this gives the confidence to the insurer to see that it has come, which indicates the right, assessment. Similarly, if we see this is creating a way forward to build trust and confidence between the hospitals, insurer, and the patient. So our next move forward is to really go forward to for the claim settlement to a digital mode. And this is where we are looking at not just what challenges the each stakeholder face, also what opportunity they see in moving from manual to digital. And this, I'm sure, in the 2 days discussion, we have been finding that this platform has been made to benefit one and all. Everyone can actually see the benefit, and as of now, even I have not seen any, problem for in using this, except for the change management which we are looking at. So in the session, we will be looking forward to the experts talking about how do we really move using this technology platform from the present way of settling claims, which is largely manual, to a completely digital mode. And till the time it happens, what initiative we should take to actually go start thinking digital first before we do anything manual, if at all we have to do. So with these, we are expecting panels to deliberate on this and give us some of the idea to move in this direction. Thank you.
Thank you, sir. I think you set the context very well. And you spoke about opportunity. So I was just doing a quick maths. So insurance industry claims were around 3.26 crores. I'm talking of the private insurance claims. And 3.26 crore claims were processed in 2025. And let's say that NHCX and ABDM blocks help in saving 30 minutes for the pre-auth, 15 minutes at the TP or insurer and 15 minutes at the hospital end, which is equivalent to something like 20 lakh man days. And if one man day costs around 2,000 rupees, let's say a very junior employee, you're talking of 300 to 400 crore savings. So that's the opportunity at the very start. I mean, even if we count nothing else, but just the sheer time saved of the manpower, let's forget everything else that NHCX provides and things provide. So that is, the opportunity is huge of all kinds. I mean, this was just one quick math that I did. Thank you very much, sir. I now move to Shri Saurabh Gaur, Secretary Health, Andhra, and we heard you and the amazing work being done by the Andhra Health Department on Sanjeevani and linking records. And my question would be that the government facilities seem to be very advanced, and then private hospitals are also very well advanced in Andhra, as we know. How do you align both towards one single digital platform? What kind of challenges or what kind of enablers at the state level that you can create and for the barrier to be broken?
Thank you so much for having me in the panel. And while I respond to your question, I'll probably talk a bit about the fact that we are running a health insurance scheme in the state also, where we are spending around, like I said earlier, 3,600 crores every year. What it amounts to is, and we are settling around, so we do it in the trust mode. We don't have a insurance agency per se working with us. So what it means is that annually we are settling around 16.5 to 17 lakh claims. It amounts to 5,500 claims per day, and around claims worth 12 crores being settled on a daily basis. Now, running it through a trust, where we have around, I'm sure there are around 40 claims per day, 400 specialist doctors who are only going through the claim adjudication process. It's a huge amount of workload. And like sir said, the fact is that the claims get uploaded through the software that we run through NTR Vaidya Seva Trust, but the claims get uploaded in as JPGs or PDFs. They are largely unstructured. There are some videos also that are uploaded. So the fact that 30% of claims go back for referrals, which increases the time. So you talked about overall at a macro level, the time being, the shortening of time cycle that can be done. Similarly, what is happening with us in terms of the repetition of communication with the hospitals and the pain that it causes to, for the people, it may be all cashless, but for hospital claims to get settled and for them to keep on delivering efficient services, it remains an issue. So definitely we want to be having a much more evolved platform and have an integrated public plus private healthcare platform. In fact, public healthcare facilities are also a part of our, NTR Vaidya Seva Trust. They drive out of that 3,600 crores, around 25% money, 900 odd crore goes to public health facilities also. And that's how we attract specialist doctors to keep on working in our facilities. So it is a huge imperative for us to make it as efficient in the public sector also. So with this, we have essentially looked at ABDM as the foundational base, make all HMIS softwares that are running in the state, in the public sector, primary, secondary, tertiary sector, and also in the private sector, making all of them ABDM compliant and having structured data coming in. And while, like sir said, while there'll be a process and a pipeline in terms of making the all the data structured, even the unstructured data also, how do we, through better OCR techniques or other AI, the scanning and the curation techniques, can we make them more structured? We have been working on that, and hopefully working closely with the claims exchange, we should be able to incorporate all of it.
Yeah, one question, the part of the question, how do you bring together the private hospitals also?
So as of now, what happens is that they are also running our instance of the software.
Okay.
The software that the NTR Vaidya Seva Trust runs. And so the hospitals are uploading their claims on that software itself. The issue actually is not just how do we bring it for government, but how do we bring it for the citizen also?
Yes.
And that is where we look at, once you do the standardization, you can pull all of that data into the patient health record app, the PHR apps that are empaneled by the ABDM, and ensure that the patients get access to all of it, and then the records through a consent-based artifact become transferable. So I believe with the NTR Vaidya Seva software that we run, and bringing a platform approach to it, and bringing modules or innovation ecosystem, whatever efficiency they are able to develop, bring them as microservices through a structured API network. That is where we are looking at bringing more efficiency into the platform.
Thank you. I move on to Mr. Manoj Chatlani, ED Non-Life IRDA. Sir, we have been hearing the entire day. What is the role that IRDA envisages in making this movement, UPI movement, come true? It's going to benefit the policyholder, the payer, the provider. Everyone seems to be benefiting. So how IRDA is going to promote this, or going to make it happen? What kind of a regulatory push, nudge, incentive are you looking at?
Good afternoon, first of all, and thank you for having me here. As you can see that we are one of the co-hosts in NHCX, so you can see that we are one of the enablers in terms of promoting NHCX, because as we discussed in earlier session also that we are going in the right directions. But of course, first and foremost for the IRDA, from a regulatory perspective, well-designed digital cash flow should actually have three major, I would say, parameters. One is the policyholder protection. For us, policyholder protection is utmost.
Absolutely.
So a digital cash flow should first of all remove or rather reduce the uncertainty of the policyholders which they face. For example, delay in settlements. And
trust factor, as sir said.
Correct. So, and the second is, I would say, market conduct. There is a friction between payers and providers, which has been, which has been a cause of.
वो मेरे बचपन से चल रही है.
Yes, cause of tussles. So, I mean, if the data is standardized and interoperable, then that trust between payers and providers will also increase. And third, I would say, from a data cash flow perspective, digital cash flow perspective, I would say it will give us a, it will let us monitor the trends, live. And at the same time, we can quickly see the outliers. So if a well-designed cash flow, gives us all these parameters, then I think, NHCX is the way ahead, I would say.
Sure.
Yeah, but at the same time, at the core of it, data privacy and security is also one of the key factors which cannot be compromised.
So since you spoke about data privacy, let me ask you a question arising out of this. So in my understanding, and that's how NHCX has been built with very strong fundamentals around data security. Is there any additional guardrail that you at IRDA is wanting to put, or is there a concern around that?
See, in terms of data privacy, of course, consent is one of the things which already mentioned that we'll take consent of the customers. But if you might have gone through the RBI Act, so consent itself may not be enough.
Okay.
Because those are the dark patterns.
Okay.
There should be a separate, kind of declaration should be taken from the policyholder.
Okay.
That he's aware that his policy records are being taken. Then those may be evaluated for settling the claims.
Okay.
So it should not be tick-based. It should rather be, more comprehensive in order for the policyholder to
at the time of policy, at the time of claim, both.
Correct.
Yes.
And in terms of guardrails, I would say, if we have live data available, those are itself the built-in guardrails. Because if you can see the outliers, you can be proactive.
Sure.
For regulator to be proactive is a necessity. Is the need of the hour, I would say.
Sure, thank you. I will come back to the panelists, time permitting, for another second round of questions. But let me try to cover everyone in the first round itself. Next is my question to Mr. Satish Kidgu, CEO of MediAssist. In the last panel, somebody said TPA is not represented, so we are very happy to have the largest TPA of India being represented here, and technology also, I think. My question to you is, what percentage of inefficiency is actually due to lack of standardization today? And part two of the question is, if digital first is in the interest of TPAs and everyone, what kind of investment, or what kind of investment industry is waiting to make it happen? I mean, why the delay? If everyone is convinced of the second part, then why this delay?
No, thank you. So I'm almost nervous to be with this distinguished panel here. Maybe I just take 30 seconds to give you one small background before I answer that question, ma'am. I have a few things in common. I'm an IIT alumnus from 98 IIT Madras, where there was no Hyderabad IIT then. Born in Andhra, worked in Hyderabad, so a lot of things in common. But before I came to MediAssist, I was a CTO of a company called Redbus. I built the Redbus tech platform. It was fully cloud-based, and we were Amazon's second largest customer, back in 2013. And when I walked into MediAssist, and I made the decision at that time to not go back to e-commerce and get to something slightly more meaningful. The day one problem that I was asked to solve was that our fax machine was broken. And I'm not making this up, because in 2013 October, hospitals were faxing discharges to us, and it was not too long ago. From there today, we're about 85% of our cashless is through some kind of an electronic workflow. And of course, we also do a lot of work on the public health side. Interestingly, what NHA has been able to do with PMJY is 100% cashless, unified interface, one common way of blocking packages. There is no discretionary spending, amounts, monies, benefits, none at all. But interestingly, compare that to the private side of the insurance. We are still a 35–40% reimbursement, like by volume. And we practically have to understand every single claim. It's not that in PMJY people don't have complex diseases or complex treatments. It's not that only people who can afford insurance have complex treatments today. Yet the approach is so different. And in fact, to answer your first question, almost all of the inefficiency we have comes because of lack of standardization today.
Correct.
So when I came to MediAssist, I thought, I was fresh from Redbus. I thought I could integrate with bus operators. There's no reason I can't integrate with the hospitals. And then we can actually pull data directly from the hospital systems. And this is my 13th year at MediAssist, and I'm still attempting to do that. But if you also look at most of where the insurtech bandwidth is going today, almost all of the work is going into converting unstructured to structured data, which is, I think, the saddest way to spend energy. Ideally, a standard structured data should have been the foundation of everything else that we do, right? So in fact, now we're requesting, we're going back to I spent about 6 years digitizing bills from 80,000 hospitals. We have over 3 crore SKUs in our system, where by hospital, by label, I know if it's a doctor, consumable, lab, injection, but it was 6 years of effort to get to that level of accuracy and collect the data. Yes, of course, we are now benefiting from it. And 2 things that have changed in the investments perspective. 1 was a bright idea, 2 was a master circular that came from the IRDA. Because for the first time, IRDA came back and said, I want patients to get out of the hospitals in 3 hours or less. But by the way, not from the last document that you get, but from the time the patient is ready to go home. I mean, that was the real intent.
Very nice,
Whether it was it was said in as many words or not. So we took that as another challenge for the last 3 years. I'm just giving you an example of investments that are going in. As we stand today, ma'am, 4,500 hospitals on an average every month trust an estimate that we give on the day of admission. Let 40,000 patients walk out of the hospitals before the bills are generated. Because the real problem that we had to solve was not wait for the bill generation problem. It is not the speed with which we were processing claims. Because our average discharge turnaround time is 36 minutes and we published it on our websites. No matter what I do, the 36 coming down to 20 is not going to make a difference.
So my question was, and is, what is the industry waiting for this to be adopted? When NHCX is providing a platform, a digital DPIT has been created, which Mediassist took long time and investment to build and is reaping the benefits, that's what you're saying. So what is the industry waiting for? I mean, sorry to put you in a spot for the entire industry to speak.
No, it's not. I'm actually proud because I was part of the working group that created the specification for NHCX.
Yes.
I was part of the joint working group of IRD and we still have only electronic workflows. We don't yet have structured data. If I were to singularly put on one thing.
Yes.
I think the more either we go into figuring out how to get data out of the HMS, or just give us the Excel sheet of the bill, not the PDF of the bill, or a CSV of the bill. Maybe I think then we'll be far more efficient. Third, today, I think there is a little bit of a complacency because there's already electronic workflow established in the private sector.
Yes, it's an email and PDF which has been, or some portals are also there.
Today, we serve 30 insurers in the private side. We work with 14,000 hospital send us cashless every month.
I request you to speak for the industry.
No. I'm just giving you a sample of the industry. Whereas in NHCX, it's only 140 hospitals that are sending us. It's 140 from NHCX, whereas 14,000 from the other sources. I think the real challenge and the best way to move that is all the digital services companies that are out there today, we almost mandate them to post a copy of that through NHCX because 85% of the interactions are already there on those platforms. And then all of us can switch our effort from integrating platforms to converting that into structured data.
That's a very brilliant point you have made that the hospitals are already using some kind of a digital interface. All that the effort should be made is to convert that digital interface to NHCX.
And they're all integrated with NHCX. You just need to push.
A good clue. Okay, so let me compliment Satish. I can share an anecdote from the PMJ early days. Mediassist was the helpline partner for 14555, and when the Prime Minister sir announced in Ranchi the launch of the scheme, आप सब लोग 1 4 5 5 5 पे call करिए, and the floodgates opened. And I was there at NHA, and then at middle of night we are discussing how to handle this surge. We were told by MTNL कि कौन बड़े करोड़पति का record टूट गया. So Satish Gudgu and me go long back, to serving the PMJ, from the very, very initial days. Okay, so now to the next person who is very important and provider को मैं insurance साइड से हूँ तो हमेशा ही हमारा डिफरेंस रहा है, एज आई सेड बचपन से रहता है. But coming to Kaho, you know, I mean, you represent Kaho, but I would suggest that we take the bigger, you know, perspective from the hospitals. Do you really think that there is a little bit of a resistance in the hospitals to adopt the change? Is it behavioral? Is it technology? Is it the fear of transparency? What it is that you know, that because I was speaking during the, you know, tea break and earlier with a lot of people, so everyone says hospitals mein kuch resistance hai, madam. So I want to understand, this audience would benefit by understanding, and how do we crack? Satish gave one clue, and I'm looking forward to that clue, second clue coming from you.
Yeah, thank you. Good afternoon, everyone, and thanks for having me in the panel. So I represent the private healthcare, even though you know, I'm also part of AHPA, where Gyaniji was here in the morning. Today I'm representing Kaho. Kaho basically represents the patient safety, quality, and the accountability. So you know, we are the vocal face for that, you know, across India. Very difficult question. If I say this tomorrow, you know, there should not be.
Fraternity is going
yeah, this forums, right? This get recorded also. But yeah, what you said, ma'am, is all the three exist in the hospital. That's the truth. You know, say for example, in Indian healthcare system, if you look at it, the primary, secondary, tertiary, quaternary. Now a fifth level has come, where the quaternary premium, 5-star, right? So how many of you think, just wanted to check with the audience, how many of you think that, you know, the India's major population goes to which category of these hospitals? Is it the primary, secondary, tertiary, quaternary, or the premium 5-star, quaternary plus? Primary?
Secondary.
Secondary, tertiary? Yeah. So that you are talking about insured class? No. So where does the insured Indian going? Last, yeah. So that segment, technology is not an issue. Technology is not an issue. Because technology, most of the hospitals, like Mr. Satish said, a lot of this quaternary, tertiary, quaternary, and the premium category of the fifth level have technology in place already in terms of HIS. Now, when NHCX is coming in, when I was operating 8 hospitals for a group called Aster DM Healthcare, I was the Telangana Andhra regional CEO. So when you look at from that side of operating hospitals, if you look at it, I have a dedicated department called RCM. How many of you managing hospitals? Yeah, a few are here. So that department was not there. If you look at 5 years, before 5 years, if you look at it, many hospitals did not have this department at all. That itself is an emerging department which was meant to settle the payers or the providers, right? So to handle the bills which are submitted and collecting the money back, only for that there is a department now in the hospital, major hospitals. I'm talking about major hospitals who deal with multiple payers. Now, when the moment it become digitized and it become easy for the insured, now we are talking only about insurance being covered under the NHCX. I think the previous panel also discussed that the majority of Indian, sorry to make this statement, I know it's a very, very welcome move by the NHA and IRDI and to come with this initiative, but will the majority Indian get benefited out of this? One question, because that's why the first question came.
So let me answer that question. 3.26 crore claims by private insurer, crore plus hospitalization by PMJ, and then again another crore plus under state schemes. I'm sure majority Indians would benefit.
But yeah,
there may be some uninsured population. We don't have universal coverage, but I think many states are having universal coverage these days. I think many states have moved to majority part. I'm still looking for the clue from the hospital side for the adoption.
Adoption, definitely, I'll come to that. So I'll ask this question. Now, even now, when you say that there's a universal adoption of the scheme, a lot of states are still to adopt the national
priority. We come to
right?
NHCX,
yeah.
Yes, please.
So that is still there. So unless until that happens, the universal adoption will not happen. That's one. Second, If you look at last year, maybe my numbers may be wrong. I think these experts are sitting here. 82% of the claims were settled in 24-25. In that, in terms of numbers, 71% was only settled in value. That's what the numbers I've got. Means 29% is not settled. It could be due to fraud, it could be due to adjudication issues, multiple issues. So there is already wastage. Maybe numbers right or wrong, maybe?
No,
I'll ask
I want to
him to respond.
clarify on this. Like, those non-settled claims are maybe not because of frauds only. I mean, some percentage maybe of course there, but many of the reasons includes the sum assured, exhausted, sublimits are exhausted.
Yes.
Which is
so there is a, I can also add to that, there is a circular by IRDA not to deny any claim except for a proven fraud. I think, and then genuine conditions. He's very right.
Yeah, so one last statement. You
Still
want
looking for the clue.
Yeah, the clue I'll tell you. So there was a statement by somebody from the audience. You give an incentive, it should be long term. I think somebody mentioned that. I don't. Yeah. So he mentioned actually. The incentive for a hospital, obviously it will help in building transparency, it will reduce the TAT, it will reduce manpower, but the statement should be that after the NHCX implementation, the settlement for the hospital is going to happen in 48 hours.
Okay.
That will bring the cash flow to the hospital, which is the most important thing for any hospital. Once I have given a treatment to a patient by buying things from the market, and I am getting my money back, not after 90 days or infinite period.
See, NHCX can be held responsible for something it is meant for. The insurance company is the payer, NHCX is not the payer. But of course, it can facilitate quicker settlement. I think that's
because
point
that's a
well
log
taken.
already, right? All the
Yes,
documents
point
have
well
been
taken.
submitted, adjudication
Yes.
is done digitally. Why not payment also done on time?
Yes,
Right?
I would have a second round.
Thank you.
I turn to you, Teetha, now. Teetha Chatterjee is partner with BCG, looking after the insurance and banking segment. We have spoken a lot about Indian systems and Indian ecosystem, and I would ask you that. Give us one example from the global, global scenarios where this kind of shift happened, and what were the key drivers for that shift to happen? Give us two examples, one successful and one unsuccessful, so that we have learnings from both.
Thank you. Thank you for the question, and glad to be here as part of such a distinguished panel. I'll give you two examples. One which has really worked, which is quite a like-to-like example of what we are doing in NCHX, is what Brazil has done over a period of last few years, right? Between 2007 to 2010, they started on this journey. I think what worked well there is that Brazil started on the standardization journey first, right? So that's one. And they co-created the standardization. And I think many of, in the previous discussions, what we hear is that one of the things that is not, that will help us unlock the full potential of this is standardization. So they started with the standardization first, they call it TISS, and over a period of, let's say 2-3 years, the standardization was built, co-created with the entire ecosystem. So every participant in the ecosystem, be it the third parties, be it the payers, be it the providers, they were all brought together to do this, and hence it started with the standardization part, that's one. Number two, and that this can be a clue, ma'am, is that, that there was a very clear roadmap of, let's say, a 12-month window that was provided to all stakeholders, that this is when we need to shift to the new standard. And then
So the hospitals were given 12 months notice that be prepared.
Sort of, yes, because after those 12 months, if the standards were not met, the insurer had the right to not pay.
That's nice. That's a good clue. Yes, giving them enough time to prepare. Yes, please.
So that's and it was done over. Eventually, it was done over a period of 2 years. But there was some, obviously there was full transparency created in this process. So that was one. I think the one example which did not completely take off so US has done a fantastic job in digitization of the health records, right? So EHRs are 97% is digitized. Is it interoperable right now? Possibly no, right? And one of the main reasons for that is...
So US is a failed example, Brazil is a successful example.
I would not call it a failed example, ma'am. I mean, it's just...
Less successful.
It's about what you're trying to solve for. if interoperability is what you are trying to solve for, it has not reached there yet because of many factors at play. One of the reasons is that to make it interoperable and to unlock the full potential, it has to, beyond, so once the grants died out, it did not take off. Beyond that, how do you make it self-sustaining? How do you have a commercial viability out of that? So for example, and one of the thoughts that I was having on this is, let's say we have the NCHX and there is a lot of, obviously it's double-side blinded, there is no data centralized, but there is a lot of data flowing through it. At a federated level, can we have, let's say, some analytics on fraud that can be beneficial to the entire ecosystem? And then that can, bring all the entire ecosystem together in a value-accretive way.
Mm. So again, I think you're also referring to the trust factor, which the CEO sir said in the beginning, that can be the first building block. I mean, over that you can build a lot many things, and efficiency, of course. But trust is something which all the stakeholders would want in the system, right? I think that be it the policyholder, be it the beneficiary or the provider or the payer. Okay, so these are a couple of learnings that we have. I hope we do have time for the second round of questions, so I will go ahead with the second round, unless I'm told to stop. Or sir, as sir suggested, sir, if I may ask one quick question to all. So in 1 or 2 sentences, what is the one single reform the ecosystem must do immediately from each one of you? Just a couple of sentences. What is the single reform you would bet your money on that we must do as an ecosystem partner, starting with the State Health Secretary?
For us, the challenge always is that how much money do I put in the insurance part and how much do we put in the public health system per se to improve our own public health facilities, with the objective of quality being paramount. And here I see a synergy in terms of, while referring to and benchmarking with the private health sector, in public health, what kind of practices can be brought? So while we look at standardization of the workflows and the electronic health record generation, I believe for the public health sector also, the same paradigm applies, and that's what we are looking at.
Very nice.
And going ahead, actually, we've been talking about clues. One of the things we've been experimenting is, in HMIS, in the hospital information system, now most of our machines also, the equipment also have a bidirectional LIS. So can we also start integrating that data and bring that data also into the PHR, rather than that coming as a secondary, again getting scribbled down or entered as a secondary piece of data again? I think that will make the patient health records even more powerful and more amenable for the patient healthcare journey.
Perfect. Thank you, sir. Mr. Manoj, what is the single reform at the regulator?
I would not call it a reform. I would say the payers and providers, first of all, should come together.
Okay.
They should reduce the friction, and there's a lot of work being going on the common empanelment front. So what we have been doing in the past, like insurers have been negotiating with 3,000 odd hospitals. Hospitals are negotiating with 70 insurers. So instead of that, there should be a grading of the hospitals.
Okay.
Common empanelment should bring some kind of standardized billing practices, standardized treatment rates,
Sure.
also, treatment protocols also.
Protocols.
Yes.
Protocols are already there by STGs are there. Yeah. Okay, Satish.
I'm solving the tech side of the problem. So one, like we've done it in GST, I think we've done service kind of codes. There is no reason why we can't publish a common set of common service codes, right? And then from publishing, and two, the hospitals actually committing to using only those codes in the bill and standardizing the discharge summary format just in 3 boxes, right? And not actually deviate from there. 3, insurers rethinking products, not from a deduction perspective, but from a payability perspective. How much of the claim can I pay, rather than what of the claim I will not pay?
Yeah.
And it becomes, and that's leading to a significant amount of conflict.
Confidence.
Last, of course, is hopefully we spend some time on making the member a little more informed before they walk in, because often it's just not it's because of lack of expectation setting that most of the grievances actually occur today.
Yes, all the ads on the TV about health insurance. लिया नहीं तो कुछ भी नहीं है. वो bed पे बैठा है, पैसे आ गए. Okay. So, Dr. Devanand, what is your wish list for the reform?
Yeah, reform should happen through awareness. No doubt about it, because now this conference is a great beginning for that. But I would suggest that, since the healthcare ecosystem is so huge in India, it's so complex, we should have statewide, district level awareness, sessions between the providers, the payers, and all the stakeholders, including maybe
so
patients
awareness
also.
among providers is what you are
Not only
suggesting.
patients also. See, patients also should come and demand
Yes,
at the
patients
providers
should
level.
come.
So patient
Yeah.
groups also should be part of such discussions, and then the reforms start happening.
Sure.
May I ask you a question
We are just running
no,
short
I
of
just
time.
wanted to ask one question. So I am told that the NHCX, when gets implemented, any patient can walk into any hospital and take service of any insurance. Is that correct?
Yes, that would be possible. Interoperable is that
so
only.
obviously patient
Yes.
is a very, very important stakeholder in this. So he gets so much of benefit. He'll start demanding that kind of services from hospitals.
Linking of records has
so
to happen.
I think the awareness has to be there. And
Awareness.
CAHO as such is obviously we have become the ambassadors for
Thank you.
awareness. We will be taking it forward. Thank you.
Perfect. I'm sure you have district offices as well. Yeah, we are going to close. Okay, we can take questions. Okay, no, Tirtha, you have to, you won't let go. So what's one wish on the reform side that you will say that this should be happening and that would make it quicken, that would quicken the process?
Ma'am, I think my wish on this is how do we take it to the next level, and let's say NCHX is bringing is setting the foundations, and like many of us have been speaking, I think the next layer on top of it is to be able to use AI. Using AI on top of NCHX will be the real unlock, and to make that happen, how do we set the standards? How do we bring the free AI framework to this? Is I think the next step. That's my wish.
Sure, that's very well said. I think the last point about the data richness of this whole exercise, the data for the providers, like every doctor, I'm sure, is very keen to know his own records. How is he performing, leave alone the public. Every hospital, every payer, every policy holder. I mean, I think the data is what we have not mentioned and what we have not covered, but given, the context, I will, we'll open the floor to the, to the audience, and if there are less number of questions, I'll turn this side. Okay, somebody can just, I cannot see the hands being raised. There are a lot of hands being raised. There is no ladies' hand, so you can go with anyone.
So
right?
myself, Dr. Mahendra Singh Rathod, I am from R&T Medical College, Udaipur, and I was served as a ex-OSD to Additional Chief Secretary, Medical and Health, Rajasthan. So, अभी जो revolution की बात हो रही थी, being a medical professional, the most important revolution would be digital literacy among the medical health professionals, because जो डेटा की हम बात कर रहे हैं, that are generated by them, और उनकी एक्सेप्टेंस बहुत ज़रूरी है. इट्स वेरी डिफ़िकल्ट कि एक डॉक्टर से हम उसका डिस्चार्ज टिकट डिजिटलाइज करा दें. मेरे हिसाब से बहुत सारे प्राइवेट हॉस्पिटल्स भी इसके लिए स्ट्रगल करते हैं. तो आई थिंक डेटा लिटरेसी एंड डेटा एजुकेशन इन अ मेडिकल एंड हेल्थ सिस्टम. सर इज़ हियर, तो मुझे लगता है कि सर ये एक करिकुलम का पार्ट होना चाहिए.
So I guess this is to the policy makers about the digital literacy for the doctors. This is a very good point that the doctors themselves may be a bit reluctant, or adoption behavioral changes. Okay.
Good afternoon, everyone. I'm Dr. Sankameshwaran from SHA Tamil Nadu. I would like to address my question to respected Secretary, sir. So we have our own state-run health insurance program similar to Aarogyasri, but instead we run it in an insurance mode. So I would like to ask, how did Aarogyasri bring about ABDM adoption in all of its private empaneled hospitals, sir? Was there any phased manner, like initially voluntary participation, then incentivization, then mandation? Or did the state move on to directly mandating it, sir?
So I guess the question is addressed to me, right?
Yes, sir.
Okay. So the short answer is that we do not have a full-scale compliance to ABDM, and we are in the same boat as probably you are. So while we have been nudging them, short of a circular from Government of India, there is no direct mandate that can be put. But the point that Tirtha made, and the Brazil example he gave was excellent actually. And that's what we found, that if you set a timeline and adherence framework to that, I believe that will go a long way. But having said that, the other things that are happening is the foundational blocks, even in the public and the private healthcare sector also, now we are mandating that the HPR ID and the HFR ID should be there compulsorily. We are making it as a part of the empanelment process also, while empaneling a hospital, so that the foundation blocks get ready, and through a general nudge, or sometimes possibly putting some friction in terms of empanelment as well as settlement of claims, you know how things sometimes are in government, bring that change also.
Yes, sir. Okay.
I
Thank you,
really
sir.
appreciate the honesty. Yes, please.
Hello, Rajesh here. We are one of the startup companies as well. One reform from our side as a request from startups point of view is how do we get empaneled with NHCX very, very fast. We have been struggling for last 6 months. We are working with 2 insurance companies. They are also struggling. The data is not coming and formats are not proper. So is there a way, because we are working with the hospitals in the back. So if we get empaneled fast, the hospitals will get empaneled fast. How can we make that faster?
Sure. I think we will, I think we'll ask the team to definitely have a word with you. My understanding was NHCX empanelment or ABDM compliances were pretty fast, M1, M2, M3. But I mean, we'll have the team, reach out to you. Any other question from the audience? Yes, I think this side a lady has raised the hand, so she gets a preference. Okay, last question. Okay, last question only. Okay.
So I'm just curious to know that any effort is done from our side. I'm just adding to what was asked. Do we have a program for doctors? Because you will not believe, now it is 10 years we have been following up. Doctors feel every other thing can be entered in the system by nurse, by lab, by this. Why is it some program for doctors? I have never heard of any program
awareness,
for
awareness.
not awareness. They should be, trained a little bit.
Trained.
They do WhatsApp every day. Why not do that little bit of
Maybe
entry?
A little short training module for the doctors.
Training module, I have not heard of
Okay,
it.
I think so. We are now running short of time. Sir, would you like to summarize? Or would you like to? Yes.
Just I want to thank all the panelists and a very good idea which they have given. Also the challenge why NHCX is still not being adopted at larger scale. So very good that some of the things which we can actually work immediately, and if IRDAI and organization like think that way, it is extremely helpful to us. And in fact, we are looking forward to those pain points or the constraint they are looking at while onboarding on the NHCX. I think in PMJ we are using that lever to slowly get them on NHCX. And probably we, for ABDM, for the new empanelment, we have made it mandatory for ABDM. Like they have to use HMIS, which is ABDM enabled, if they want to be empaneled under PMJ for the new empanelment. For the existing one, we are going to give some more time to get HMIS enabled with ABDM. And some of the states have already started giving the deadline by this date, you should get ABDM enabled HMIS. For NHCX, we have been not mandating, mainly for the region we didn't have many integrators. Today we gave 3 integrators that certification that their HMIS is now NHCS integrated. And I think the question is right that it's taking time. I think this first 3 which have gone through and successfully passed through is showing the way. Now the new ones will be much faster. There are many who are already in the sandbox environment. So while ABDM enablement has become a very smooth game, and almost 400 applications are already M1, M2, M3, and around 1700 more in the pipeline. So there is a good number which is showing interest, and our people are doing integration. For NHCX, it's taking time, and I think this NHCX hackathon and this meet has also given us a lot of idea and the need to go forward in a real fast pace, and that we will do. And thereafter, I think we will again use that lever of PMJ to make hospitals to submit claims directly on NHCX.
Yes.
In the meantime, we would also like to take help of expertise which is there with organization like MediAssist, that what really can work in this case, and their access to so many hospitals will actually help us if they themselves come with the idea how they can onboard to NHCX. And then the Brazil example was given, which is something which gives a great confidence,
yes.
that this is not a mandate, this is just giving a
Sufficient time notice.
sufficient time to come. And if IRDAI agrees to that, beyond that time, if you don't come, your claims can be rejected.
Absolutely.
That is something which gives a huge signal, even if we don't mandate it. It gives a huge signal that everyone has to move in that direction.
Yes.
So I'm very hopeful that this will be giving us a lot of idea, and we'll work on that. And so thank you very much for this panel discussion and for participation in the panel.
Thank you, sir. And my apologies to the panel if I pushed anyone too hard to come up with some answers, right answers. Thank you very much. Thank you very much, sir.
Thank you, ma'am, and our esteemed panelists. I would like to thank our moderator and panelists for sharing their perspectives. And as a token of our appreciation, I request Malti ma'am to kindly present the tokens of appreciation for the panelists. Dr. Sunil Kumar Banwal, Shri Saurabh Gaur, Shri Manoj Chatlani, Shri Satish Gidugu, Dr. Devanand, Mr. Tirtha Chatterjee. And to thank our moderator, I request Shri Kiran Gopal sir, JSN MD NHA, to kindly present a token of appreciation. Thank you, everyone. I now invite Dr. Sunil Kumar Banwal, CEO, NHA, Shri Saurabh Gaur, Secretary, Government of Andhra Pradesh, Shri Kiran Gopal Vaska, Joint Secretary and Mission Director, NHA, and Shri Ajay Seth, Chairman, Insurance Regulatory and Development Authority of India, to kindly take their seats on the dais. As we come close to the conclusion of this two-day event, it is now my privilege to invite Shri Kiran Gopal Vaska, Joint Secretary and Mission Director ABDM, NHA, to share some reflections. Through his leadership, initiatives such as ABDM and the NHCX are helping shape India's digital health ecosystem and creating the foundation for more efficient healthcare services. I request Sir to please address the gathering.
Thank you. Shri Ajay Seth, Chairman IRDAI, Shri Dr. Sunil Barnwal, CEO NHA, Shri Saurabh Gaur, Secretary Health, Government of Andhra Pradesh, colleagues from NHA, participants in this event comprising of researchers, students, insurance companies, hospitals, and our co-hosts, the faculty and resource persons from IIT Delhi. Sorry, I've been still in IIT Hyderabad. Sir, over the past 2 days, in fact, sir, was a culmination of an effort we have taken up for the past nearly 1 month, sir. In fact, the idea of this hackathon originated from the meeting that we had jointly with IRDAI in Mumbai on the 8th of January, where under your direction and guidance, we called insurance companies and hospital associations and also some tech companies to understand the bottlenecks in the adoption of NHCX. As you are aware, sir, the entire PMJY system currently runs on the claims exchange, and we have also onboarded the CGHS pensioner claim processing, the CAPF claims processing onto NHCX, and we are also currently conducting a pilot with ESIC, sir. And also many state government sponsored schemes are also currently running on this, sir. Now the next frontier, sir, as you are aware, was to also onboard the private sector, the private insurance, for which the overall NHCX has been built. And from the insurer side, sir, with the support of IRDAI and the guidance, we've been able to onboard almost all the insurers who are actually dealing with health insurance. I mean, quite a few products of theirs are also onboarded. The challenge is mainly to onboard the private hospitals onto this, and as of today, we have close to 700 odd hospitals and more than 150 different types of products we have been able to onboard, sir. But then the universe is much bigger, and in the meeting we had on the 8th of January, certain issues were highlighted by the hospitals and the tech companies as teething troubles while onboarding onto NHCX. And therefore, the problem statements of this hackathon were identified based on those issues. So we had overall 5 statements, of which 3 were part of the hackathon and 2 were ideathon, because we also realized that we need to also put NHCX more as a business case to hospitals and not just as a simple technology case. So from the hackathon side, sir, we had problem statements that were about how do you create connectors that can seamlessly help integrate a legacy HMIA system with NHCX. How do you convert scanned documents into structured FHIR objects which are essential for sending claims through the claims exchange? And then also, sir, given the kind of vast variety of insurance products we have and the requirement of converting insurance products which are mainly PDF contracts into a FHIR object, so how do you do that? Creating utilities for that was also one of the challenges, sir. And on the ideathon side, we said we need to identify more and more use cases of how the claims exchange, by utilizing the additional building blocks of ABDM, can help in reducing abuse and fraud in insurance. So that was one of the ideathons questions. And the second one was, how can we further utilize NHCX for optimization of claim processing, both in terms of the time taken and also in terms of cost involved? And I'm happy to report that we had a very good participation, where more than 300 participants registered for the hackathon, and we finally received 111 solutions. Each of the solutions had, on an average, had at least 20-25 each of the problem statements had 20-25 submissions. And we had juries comprising of industry experts, our own tech teams. So we got a lot of support from the India InsurTech Association, IIT Delhi, IIT Hyderabad also supported us, sir. And finally, teams were identified, and 3 winners in each of the categories were identified, and they were felicitated as part of this closing ceremony, sir. In addition, we also had very engaging panel discussions where the discussions were held on how to further standardize insurance claims. So the joint committee that was initially formed between IRDA and NHA, which actually gave rise to the NHCX, sir. That was the first time when we actually talked about how do we standardize claim, and then how do we digitize claim, and that is how the whole idea of creating fire objects for claim had actually come in, and that went into the development of under ABDM, and we were able to develop this. So the panels were on how do you take it more digital. The second one was, one very important panel was on AI, the advent of AI and how it can impact health insurance and the health sector in general, where the speakers really talked about how it can actually become help in creating more customized products, and the fact that ABDM can now help in creating longitudinal health records, which will be much more useful for the insurance company to create customized products and therefore have more customized insurance premiums rather than going by median or average values. And in also about there was also idea of using telematics for life model, where how do you take a lot of information from various aspects of life, including geography, including disease parameters, including the risk appetite, lifestyle, etc., so that we are able to create more better insurance products. And today's panels also highlighted on how we can scale further NHCX, and CEO NHA led one of the panels. So overall, as you can see, the participation has been very, very encouraging, and your presence also here gives us immense confidence, and the fact that the insurance regulator supports us and is pushing this initiative is a very, very important aspect for this. And we've been also able to identify some real good talents whom we can harness further. And this hackathon will not stop here, sir. The CEO NHA has already given very clear direction on how we will be utilizing the solutions and also the providers of the solutions going forward, in first maybe doing some pilots and then scaling them and actually taking them to population level scale. And thanks to the presentation by Secretary Health Saurabh Gaur sir, he already showed how Andhra Pradesh is doing it through their MedTech challenge. So this is a very good learning we are having between the center and the state also. So this overall this event was very, very useful that way, sir. And the support that we are seeing is very encouraging, and we really look forward to taking NHCX to the next level, where it becomes that binding force and also that entity where we are saying that can revolutionize the way we process health claims in our country. So this is overall the report of how the NHCX Innovation Meet has happened today, and I thank you once again for gracing the occasion, sir, and I thank everyone for participating, and CEO sir for his guidance. Thank you very much.
Thank you, sir, for those remarks. It is now my privilege to invite Shri Ajay Seth, Chairman IRDAI, to deliver the valedictory address. As chairman, he plays a pivotal role in guiding the regulatory framework that strengthens India's insurance ecosystem while encouraging innovation and digital transformation across the sector. We are honored to have you here with us today, sir. I request to kindly deliver the valedictory address.
A very good afternoon. First of all, my thanks to NHA, Chief Executive Officer, Dr. Sunil, Joint Secretary, Mr. Kiran Gopal, and Secretary Health from Andhra Pradesh government, Mr. Saurabh, and also to the host here, IIT Hyderabad. Apart from being pleased with the matter, which is very critical for insurance sector, health insurance, the need and the potential for any insurance product today is the health insurance. Provided we can be in a position wherein it is affordable for most Indians. There will always be some proportion of our population for whom the government has to provide. They can't have a market-based insurance, but for a large population, affordability and the quality assuredness of service. If you can do these two things, there's a ample need is there, because ability of government system to deliver health services will always be limited. I'm particularly also happy that this event NHA chose to host it here or approach IIT Hyderabad. Is a new generation IIT, and when talking about innovative solutions, at times the young people have much better innovation ideas than people like me who have done enough years, but we lose on the innovation, we get on through the experience. But the young people is a young IIT, so that's the place to be in. Here I would like to recall and bring it to your notice, which you have already read. Just about 3 weeks back, Honorable Prime Minister, in an interview to PTI, talked about where we need to travel and how we need to travel in our journey for Viksit Bharat. And he talked about Reforms Express. He mentioned 3 aspects. One is structural reforms. He talked about overall for the country, but health sector is one sector which does need those structural reforms. Bring in the new institutions, not in terms of more hospitals, that anyway would be needed. New ways of doing the things, and NHCX is one such way. And how do we scale it up? It is already tested, it at a scale, proven, but to make it go-to platform for claim settlement. Second, Honorable Prime Minister talked about deepening innovation. We have to find our own solutions. No solution of, especially in health sector. In terms of treatment, researches are going on, but when it comes to the management of the health sector, our problems are ours. We have to find our solutions. And there, this hackathon, wherein young minds come together and saying, hey, I've got a great idea. I've got an innovative technological solution. If you can join the two, I can come out with very effective solutions. So that's the innovation, and again, Prime Minister talked about deepening innovation. And health sector, especially the claim settlement, is one area where innovations are possible. And then he also talked about governance and simplification. At the moment, it is a fragmented market. There are hospitals which are tertiary care, corporate run versus a 5-bedded, 10-bedded, a single doctor-run hospital, each providing the services. And of course, there are government hospitals, very well-run government hospitals, district hospitals, even the PSCs and CSCs, and there are varying variety and varying level of competence in the country. But what is the idea, underlying part which Honorable Prime Minister was telling us? It is improving productivity, getting better outcomes with lesser efforts, lesser money. That is a game we will have to master and then move forward. As a country, what we are spending today on health, governments spend about 1.5 to 1.7% of GDP every year. The numbers may vary, both central government and government of India and state governments put together. Citizens spend about 2.5% of GDP. Now convert them into number. 2.5% of GDP will be roughly about 10 lakh crore. Various. That will include from buying buying medicines and going for a tertiary treatment. The entire gamut is about 10 lakh crore. The organized schemes, what their expenditure are, there are different schemes. First, Ayushman Bharat, PM Jai scheme, all put together, combined with what the state governments put into that pool, maybe of the order of maybe about 25,000 crore given. 10, Government of India, another 15, and I'm coming, state government schemes will be somewhat different. Different state governments have provided their different coverage. So going beyond that, all put together, as CEO is mentioning, the total expenditure may be of the order of about 40,000 crore. Then of course there's a CGHS, which is about another 10,000 crore, plus there are other organized government departments which they have their own schemes, plus ESI, which is about 10 to 15,000 crore. Medical expenditure there is of the order of about 10,000 crores. And then comes the health insurance, which is a market-based health payment system or market-based health solutions, wherein the last financial year, the payouts were of the order of about 80 to 90,000 crores. So all put together is about 1.5 lakh crore out of 10 lakh crore is the one which is the organized way. That is, somebody is paying for somebody and there is a health service provider. And that is the first space for National Claim Health Exchange. What does it mean? It is 15% the total private health expenditure. 15% may appear to be a smaller sum, a smaller proportion, but look at 1.5 lakh crore. It is not a small sum. It is a big amount. It is a fairly big amount. NHCX has already shown that for Ayushman Bharat is up and running at a scale system running. But there they spend per person, maybe the order of about 1,000, 1,500 rupees per annum. Market base won't work at that level because Ayushman Bharat is a basic product, wherein market base, those who were ready to pay for the premium will expect, they want to have a choice and they would like to have a more ride-on, etc. But for a market-based product, and then I'll try to connect it with NHCX and where lies the challenges, there are challenges there in market-based health insurance. Information asymmetry between the policy holder who may become a patient at some point in future, because at the time of purchase of the policy, person is healthy. Unhealthy people, there is another story goes on, pre-existing diseases, etc. But one is saying, if one were to fall sick in nth year, I am paying premium year after year, and that year, in that event, health insurance company will pick up my expenses. That is what a future promise health insurance company does. So what is the condition of the policy holder is not known to the insurer. First level of information asymmetry. If that policy holder has an adverse event, health event, goes to the hospital, doctor is the best judge to decide what is to be done. Patients may have the best treatment. Doctor may say best treatment may not be needed, as a practical treatment is needed, but everybody says, I need robotics. A doctor may say, my hands are better than a robot, I can treat you, but no, I want a robotics. Again, that has a different cost and line of treatment. Doctor is the best judge, but patient may have the eagerness that go in a different path. Insurance company and the health provider, there's again information asymmetry, trust between the three elements. So this is information asymmetry. Second challenge which arises is indeterminate quality. One is paying premium today, event may happen, may not happen, which will happen in a particular year. What will be the experience? One gets to know only when that event happens and the hospital says, cashless will not be possible because your health insurance have said cashless will not work out for you. Or that everything happens Payment doesn't happen on time. So indeterminate quality. And third one is a constrained economics. The risk pool of health insurance is limited, is 85,000 crore, but that is not enough. Treatment cost at times can be a lot more. So as a result, in the last 3 years, premiums have been going up in about 10 to 12% per annum, whereas inflation, 6%, 5% of that order. So increasingly, if it is increasing by another 3 to 4 percentage point more than the inflation, it becomes becoming unaffordable. So there is a challenge coming up there. Why I am bringing up that aspect? NHCX have shown, and I'll just come to that aspect, because government promoted schemes are for basic products. PMJ is a basic product. First, it has been working well, this is my impression, and NHA will know a lot more. In whichever state, public institutions are well run, they have got good infrastructure, good set of doctors. PMJ is also doing better than those states, because only the spillover goes to the private sector. In those states where the health infrastructure is weak or the health services are not top-notch, the entire dependence comes from the private sector, enrollment or the empanelment of those hospitals. So the willingness of the private hospitals to get onto PMJ for us will be on a weaker side. That is my impression, but NHA will have more information on that aspect. Similar manner, ESI. ESI runs his own clinics, his own set of hospitals. Only for spillover, they have a contracting out wherever their presence is not there. But on the other hand, health insurance covers the entire country. So NHCX, to get adopted for the country as a go-to platform, it also requires economics of the sector to be fixed. It also requires the pain areas of the sectors to be fixed. Because IT solutions, the best of the solution will work well when the real part, lack of a technology, can bring about efficiency, but it can't fix up the problems of the real sector. So it has to be work in the two, and that is where I say between the regulator, Government of India and state government, the work has to happen in that direction to make it really at a scale go-to platform for the health for the health sector. Of course, it is a much superior platform. It's a well-designed, well-tested platform. Just look at this aspect. The largest ID next to Aadhaar is Aabha ID. It's about 80 crore people. Just think of it. We have all been witness to that. We have all been using Aabha ID. The COVID period. Because of the Aabha ID, that entire vaccination program in a very short duration of time could be done because this platform was available. In an emergency situation, in a normal situation, it can work even better. Of course, it has set various number of standards. But as Joint Secretary Mr. Kiran Gopal mentioned, and I'm glad that Hackathon has come out with practical solutions in terms of legacy challenges. One, in terms of each hospital has its own way of health management, which is records. Not the records, the billing system. Second, the records. Doctor is good in writing prescription. He is not a data entry operator. That challenge would remain. So while coming here, I was having a conversation and Mr. Kiran Gopal was briefing me that Bihar is one state wherein they have somehow persuaded the doctors to do it in the system rather than writing prescriptions. But that's going to be a challenging one. Is not a practical at all places because all doctors may not be comfortable in doing it. He's there to treat. He's there to diagnose and treat the patient rather than writing into a system, unless it is some voice enabled or something. I'm not sure whether, it's possible, perhaps. He can just speak that this is a disease and the system captures it. If that kind of a perfection can be brought in, it can work in that manner. Then it is doing it from the doctor's perspective a solution. But to expect a doctor to do a data entry, it may succeed in few areas, few hospitals, but otherwise it will not, especially in a government system. I do recall about 1.5 to 2 decades back, single doctor clinic. he will do his own data entry and then write the prescription thereafter. Not write the prescription, he will, that will go to the next level, etc. But that is an individual initiative coming up. So this hackathon, getting into that how the health management system, meaning that the billing system, the record system, and the insurance side. I'm glad that the three problem areas, good solutions have come in, and Dr. Sunil was mentioning that he will share with me and will try to take them forward. But do not let it be the end of the effort, because these are the three best solutions at this point of time. Our effort should be how do we make those three best solutions popularized. But that should not be the end of innovation. Because whatever could be thought of today, I'm sure the next set of people tomorrow will think of, hey, I can do it better. And I'm a great votary of a 1990s, being a certain age, we can go back to the 90s ad, a surf ad, uski kameez, meri kameez se safed kaise. The people who have been there in 90s can connect it, or the people of my age can connect it with that kind of a thing. So if somebody can innovate, I can innovate it better. With that spirit, we'll find more solutions to that aspect. I'll leave few more thoughts with the NHA, because this is a work which requires Government of India, represented by NHA, and we as a regulatory authority, wherein the payers of course is a policy holder, but thereafter they buy the policy, the payer is the insurance companies. There is a keenness to join, provided there's a good solution coming up, and plus the state government. We have to get the state governments involved in a much bigger manner. They are a very, very integral part of the solution coming up. From two perspectives. One, a number of them are running their own schemes. They want to provide a coverage to a much wider population. Second, health sector by and large is an unregulated sector. Nothing wrong with it. It is not possible to regulate that sector. But what can be regulated and what should be the Clinical Establishment Act, bringing in more transparency. But who is the regulator there? State government. Sitting in Delhi or we are in Hyderabad as a regulator, or somebody will say the hospitals will come on board, has to be with active participation of the state government. So we have to sit down with the state government saying, hey, that would mean better health services for your people in your state. So that is a work which we need to do, and the way to move forward is Clinical Establishment Act through a better transparency to be brought in, and that's an area where we should be working on. Then of course is areas like what should be the rule engine, what should be the rates, etc. Therein from the ERDI, we are working with both payers and the providers, and there is a new term which I heard just about last month, a new set of PPP, and that is the public payer and the provider. So the public, insurance companies and health service provider. Trying to get both payers and providers together, we have been working with CII, and we had 2 separate rounds of meetings, both with the payers, first with the payers, then with the providers. Now, next to next week, 17th, we are going to have a combined meeting. That how do we get the issues resolved, the real sector challenges, where the shoe pinches to whom, trying to get it resolved, the matter with them, so that they can move forward, is a journey which we must undertake, as Honorable Prime Minister has guided us. We have to move towards much better productivity and much better level of services. So here on this forum, and we stand ready to work with NHA and with the concerned state governments, whoever is willing to get onto this, and of course, as insurance sector regulators, to facilitate a much better relationship between payers and the providers. So I'm glad, and I would like to congratulate all 111 participants who came out with an idea, and those who have been selected here, we would actively work. Those who have not been selected as the best, remain engaged, because your ideas will also be worth pursuing so as to come out with a better solution. Thank you very much for your time.
Thank you, sir, for your insightful remarks. May I now request Dr. Sunil Kumar, sir, to kindly present a token of appreciation to Shri Ajay, sir. Thank you, everyone. To formally conclude this event, I now invite Shri Nikhil Dongari, Director IT, National Health Authority, to deliver the vote of thanks.
Respected dignitaries, esteemed speakers, participants, and colleagues. As we come to the close of this remarkable two-day journey at the NHCX Hackathon 2026, it is my privilege to deliver the vote of thanks on behalf of the National Health Authority. First and foremost, I extend my heartfelt gratitude to our distinguished guests and speakers, leaders from IRDAI, IIT Hyderabad, state governments, hospitals, health techs, and insurtechs, and finally my organization NHA, who have shared their wisdom, experience, and vision. Your insights have illuminated the path towards a digital-first, standardized, and patient-centric health ecosystem. A special thanks to our panel moderators and experts who steered thought-provoking discussions on claim settlement, AI-driven insurance transformation, and scaling NHCX adoption. These conversations will undoubtedly shape the future of health claims innovation in India. I would also like to sincerely thank our jury members, Professor Nagarajan, Manisha Mantri, Igneshwaram Acharla, Dr. Babatosh Mishra, Naveen Narayan, Segar Sampath Kumar, Malti Jaiswal, Dr. Ajay Nair, whose evaluation helped us identify the hackathon and ideathon winners, ensuring fairness in the competition. I wish to acknowledge the tireless efforts of the organizing team, our co-partners IRDAI, GIC, IIB, IIA, Google, NABH, Nat Health, NRCES, and IIT Hyderabad. Behind the scenes, your dedication ensured that every session ran seamlessly and every participant felt engaged. Finally, to all participants of this two-day event, thank you for your energy, curiosity, and commitment. The true success of NHCX lies in the community we are building together, a community that believes in collaboration, transparency, and technology for better health outcomes. As we conclude, let us carry forward the momentum from these 2 days into our institutions, policies, and practices. Together, we can make healthcare more accessible, efficient, and equitable for every citizen. On behalf of the National Health Authority, I once again thank each one of you for making event a resounding success. With that, we formally close the NHCX Hackathon event 2026. Wishing everyone safe travel back to your home. Thank you.